From the Library of Congress in Washington, D.C.
Ladies and gentlemen, welcome to the Library of Congress, to the Kluge Center, and to our meeting today, exploring important questions around depression and its treatments. I'm Bob Gallucci. I am the director of the Kluge Center. I'd ask you at this time to do what I'm going to do, which is to put your cell phones on stun or silence or whatever works well for you. Also, a word of announcement / warning. Today's program is being filmed for the Library of Congress and the Kluge Center websites, as well as for Kluge Center YouTube and iTunes U channels. The Kluge Center, where you now are, was created 15 years ago through a generous gift from philanthropist John W. Kluge. It brings together scholars and researchers to distill wisdom from the library's rich resources and to interact with policymakers and the public. The center also awards the Kluge Prize, which recognizes achievement in the study of humanity. It was awarded to philosophers Jürgen Habermas and Charles Taylor last year, 2015. The Scholars Council is here today. The panel we are hosting is led by Scholars Council member Philip W. Gold as a part of the annual Scholars Council meeting at the Library of Congress. The Scholars Council is a body of distinguished scholars convened by the Librarian of Congress to advise on matters related to scholarship at the library, with special attention to the Kluge Center and the Kluge Prize. In formation since 2001, the Council comprises 14 leading thinkers and includes winners of the Pulitzer Prize, the Holberg Prize, Balzan Prize, Guggenheim and Fulbright Fellowships, and those listed among Time Magazine's most influential people. Dr. Philip Gold has been a member of the Scholars Council since 2004. He received his undergraduate medical degrees at Duke University and his postgraduate medical training at the Harvard Medical School. He has been at the NIH Clinical Center since 1974, where he served as Chief of Neuroendocrine Research in the NIMH Intramural Research Program. Dr. Gold and his colleagues have pioneered the elucidation of fundamental mechanisms of the neurobiological biology, of the stress response and its dysregulation in major depression. He is an author of more than 500 publications, including a series of 9 full-length articles in the New England Journal of Medicine. The Kluge Center is all about bringing scholars together from different disciplines and encouraging conversations and reflection that might not otherwise happen. Our panel today does exactly this. Dr. Phil Gold has been thinking about these topics for decades from a scientific angle. In addition, as a medical doctor, he brings a deep concern for the human condition and a drive to improve the lives of patients. As he wrote for a recent interview for the Kluge Center blog, and I now quote Dr. Gold, "Depression is an insidious illness infiltrating core attributes that define our humanity. For this reason, I have an abiding and profound antipathy for its treachery. Depression humbles us by making us seem far less than who we are. In so doing, it robs us of the major epochs of our lives, past, present, and future." I'm glad he and his distinguished colleagues are with us today and will be reflecting on these important topics. Dr. Gold.
Thank you very much for those kind words. It's a pleasure to be here. And back at the Scholars Council meeting, this will be my last, and it's been a magical experience. We have three speakers today. I will start and speak on general aspects of major depression and how we've come to understand it as a neurodegenerative systemic disorder. And then Dr. Ray DiPaolo, who is chairman of the Department of Psychiatry at Johns Hopkins University and head of their depression research program, and one of the world's outstanding geneticists in psychiatry, will be speaking on the genetics of psychiatric disorders, and especially depression and bipolar disorder. And Dr. Carlos Zarate, who is a laboratory chief at the NIH, has made, I think, one of the most important discoveries in the last 25 years in psychiatry by finding that the drug ketamine is able to produce rapid and full remission in treatment-resistant patients in as little as an hour. And just yesterday I saw a preprint of his paper, which appeared in the journal Nature, where they have worked out the mechanisms of action of ketamine and discovered other compounds that have similar effects, but with fewer side effects. We'll each speak for about 40 minutes and take 10 or 15 minutes of questions after our talks, and that will still leave about 15 minutes at the end of the session for questions. Let me just type in my information here so I can get online. Yep. Pardon me just a moment. Oh no. All right. This was bound to happen. I'll try it again. Forgotten my initials here. Believe it? Yes, I have this. No, I don't even have a hint here. I've been using this password for years. All right, ready to go. Thank you. Okay, let's see my person. Oops, I'm at the back here. I'm so sorry that this is going so slowly. I do research in stress, and now I know what it's like. Let's see. Here we go. I'm talking about depression as a dysregulation of the stress response, and we'll be describing some of the newer findings that have emerged, which establish depression as a full-blown disease, a systemic, full-body disorder, which has neurodegenerative aspects and is a progressive disease, much more serious, I think, than we had previously appreciated. The slide there is a schematic of something that Hippocrates said 2,000 years ago, that we are all beset by disturbing forces that maintain balance or equilibrium, and fortunately they are counteracting or reestablishing forces that reestablish the balance or equilibrium. And today we call the disturbing factors stressors, the balance of the equilibrium, homeostasis, and the counteracting reestablishing forces as adaptive responses. And two adaptive response systems are the stress system and the immune system. Galen referred to these counteracting reestablishing forces as vis medicatrix naturae, the healing forces of nature. And as I mentioned, we know that depression is a dysregulation of the stress response, and I'll talk with you a bit about what the stress response is all about. We first presented this in a two-part series in the New England Journal of Medicine entitled Clinical and Biochemical Manifestations of Depression, Relation to the Neurobiology of Stress. And what is the stress response? Say you're being chased by a bear and you fear for your life. The first are fear-related behaviors and anxiety, and these are essential for survival. Without them, there is not sufficient motivation to escape the threatening stimulus. There is a very extensive central nervous system apparatus for generating anxiety deep in the brain, and it sends many, many fibers to the cortex to announce for the conscious experience of fear. But the cortex sends relatively few wires down to the anxiety center, and for that reason, we can't really persuade ourselves not to be afraid or not to be anxious. And that's the price we pay, I think, for survival. But I think it's one of the tragedies of human evolution. There's a decreased capacity for pleasure, and the reason for that, or one of the reasons for that, is to prevent distraction along the way, since the attention must be focused only on the threatening stimulus. Similarly, there's an inflexible mood and cognition. The mood should not be bouncing around, and cognitive style is really very fundamental, either programs that have been generated during past stressful experiences or somewhat instinctive responses. Stress hormone production is always an invariable part, and I'll be talking a bit about some of these stress hormones, cortisol and norepinephrine. There's a redirection of fuel to the bloodstream in the brain, and this increases plasma glucose, which the stress brain needs in order to mount an effective stress response. It occurs through insulin resistance, and I can talk a little bit about that later on when I show you some data. There is premonitory inflammation, and so when we are stressed, whether it's psychological stress or whether it's a physical stressor, there is a premonitory activation of the inflammatory response, and presumably that occurs perhaps to prime the system to respond to a possible injury that is inflicted by the stressful situation. And there is also similarly an activation of coagulation as a stay against possible hemorrhage, so that the body is ready for this before it happens. Inhibition of neurovegetative programs. What are these? Again, these occur in order to prevent distraction or the wasting of calories on programs that are not essential. So that if you're being chased by the bear or if you're very stressed, you won't stop and eat. You won't stop and look at a beautiful scene. You won't stop to rest. You won't stop to sleep. You won't stop to participate in sexual activity. All of these are suspended during the acute stress response. And there is something called, there are increased neuroplasticity and neurogenesis. We just learned that not long ago, and I'll mention a little bit about that in the next few slides. But these are intracellular changes that occur invariably during a stress response that is controllable and over which the individual feels they can master. And there has to be effective termination of the response. It has to stop when it's no longer needed, rather than to linger for long periods of time. Now, what do I mean by neuroplasticity? In B there and C, you see these are projections from neurons. They're like trees, dendritic trees. And normally they're quite robust. With a very severe stress, down at the bottom, they are diminished significantly, and with stress that is manageable, mild manageable stress, actually this neuroplasticity increases. On the right, you see two slides. The bottom one shows neurogenesis. We now know the brain makes new neurons. They're born and they make connections with other neurons, and they're essential for an adaptive response to stress. The bottom photomicrograph shows what that is like at baseline, and on top, that is the staining of these new cells during controllable stress response. This shows again on the left the control, normal dendritic tree, and below how it's paired off in the prefrontal cortex and the hippocampus. On the right, what happens actually is that this tree actually burgeons in the amygdala fear center, which is essential for the conscious experience of fear, and which plays a very important role in the experience of depression. Now, there are several forms of depression. I'll talk about two principal ones. The first is melancholic depression, and it affects about 35% of patients who develop major depressions. And this form of depression belies the term depression in that it is a state of hyperarousal. Its cardinal manifestation is anxiety, directed at self and experienced as a sense of worthlessness and meaninglessness. And so it's an existential state. Inhibition of the capacity to anticipate or experience pleasure, inhibition of sleep, appetite, and interest in sex. There's inflammation is activated during depression really rather considerably, and there's some data to suggest that not only may it be premonitory, but that it may even occur and predate the onset of the depression. There's insulin resistance, so blood sugar rises to help the stressed brain, increased blood clotting, and these events occur even during psychological stressors, just as powerfully as if one were chased by a dangerous animal. Inhibition of the growth hormone and reproductive endocrine systems to save energy for the stress response. And there's a marked decrease in depression of neuroplasticity and neurogenesis, which are very much involved in the depressive pathophysiology. So melancholic depression, this really is a rendition virtually exactly to what I had earlier showed as what transpires during the stress response. Fear-related behaviors, the inflexible mood and cognition, stress hormone production, redirection of fuel to the bloodstream and brain, inflammation and coagulation, inhibition of neurovegetative functions. Here, decreased neurogenesis and neuroplasticity. And there is an insufficient termination of the stress response. It gets stuck, as it were, in the on position. Here is a schematic of the brain. If you look at the green area sort of in the center to the left, that's called the subgenual prefrontal cortex, which Wayne Drebitz discovered was significantly reduced in size, and its activity is abnormal in patients with familial major depression. These are people who are depressed and who have first-degree relatives who are depressed. And this plays a very important role in the depressive syndrome and during the stress response. It regulates and restrains the amygdala fear system and hopes to, and it, when it's working properly, prevents there being maladaptive levels of high anxiety. It plays a large role in self-assessment or in how we feel about ourselves. It estimates the likelihood of punishment or reward. It modulates the pleasure in the reward center. It restrains cortisol secretion and norepinephrine secretion. And in patients with familial depression, it's reduced by as much as 40%. And here you see the healthy volunteers and the bipolar and unipolar depressed patients showing highly significant decreases in the volume of the subgenual prefrontal cortex. And so what you get is a syndrome where there's excessive anxiety. Self-assessment is a feeling of worthlessness that goes along with anxiety about the self. Increased estimate of the likelihood of punishment, a downregulation of the reward center, a release of increased cortisol and norepinephrine secretion, and this neuropathic change, which is one of many in depression. This is not the only one. But there are many that occur in various centers that control cognition, bodily functions, sleep, and so on. Down at the bottom you see amygdala, and there is the arrow goes to that yellow structure. And the amygdala fear system is essential for the conscious experience of fear. It restrains that subgenual prefrontal cortex and makes it more abnormal. And it really puts a brake on the pleasure and reward center. It's very hard to anticipate or experience pleasure when you're very anxious. Severe anxiety is virtually the absence of any good feeling. It stores negatively charged emotional memories. It activates cortisol and norepinephrine secretion, stress hormone secretion. It's increased in size, and there is more neuroplasticity during depression. So the amygdala is really firing at full force in the midst of a depression. And its neuroplasticity is actually increased during depression, which is what we wouldn't like to see. Then there's an area called the ventral striatum, which you see there's an arrow there to the red structure, which is just to the right of the subgenual prefrontal cortex. The ventral striatum it plays the most significant role in the anticipation and experience of pleasure. And it's involved in reinforcement and in drug addiction. It sets the tone of motivational salience. In response to pleasurable stimuli, patients who are depressed have a subnormal activation of the ventral striatum, do not respond to pleasurable stimuli. And its size is significantly diminished in depression. Tissue is lost during the active depression. And so this is responsible for one component of the depression, which we term anhedonia, or the inability to experience pleasure. And one last structure I'm talking about is the hippocampus. And it's a horseshoe-like shaped structure. This is a different cut of the sagittal brain. The hippocampus subserves multiple memory functions, regulates spatial relations. It modulates the subgenual prefrontal cortex. There's an area in the front of the hippocampus called the anterior hippocampus, which sends a single wire without prior connections to the subgenual prefrontal cortex and is thought to modulate it significantly. It restrains cortisol and norepinephrine secretion. It's the principal site where neurogenesis takes place in the brain, where it is increased during a normal stress response and decreased during severe stress or depression. And its size, and we've known this for quite a while, is significantly reduced in patients with depressive illness. So there's loss of tissue. There's more loss of tissue in depression than there is in Parkinson's disease. And depression is all the more problematic. Parkinson's disease is a terrible disease, but it's generally a disorder of older individuals. Depression has its onset not infrequently in children, adolescents, and young adulthood, and it's a lifetime disorder. Then there's an area called the hypothalamus, which you see there at the base of the brain, and it connects to the pituitary, and it produces the hormone called CRH, which our lab has worked with considerably. And CRH is released from the brain, stimulates the anterior pituitary just outside of the brain, and that stimulates the secretion of cortisol. But it's the brain that drives cortisol secretion. And its secretion is highly elevated in depression. We've now finally nailed down that depression is really a full-blown systemic and neurodegenerative disease rather than a simple chemical imbalance. This concept comes alive in research that shows, which I've just shown you, with a loss or gain of tissue in several highly specific sites in brain. And these pathologic changes in brain progress if the depression is not effectively treated. The damaged areas perform functions relevant to the core biological and psychological dimensions of depression. And I'll just repeat these again, but you'll see these are the major components of depression. Anxiety, how we perceive ourselves, the likelihood of punishment or reward, the capacity to anticipate or experience pleasure. We now know precisely where these tissues are, what the tissues look like, which cells are destroyed, and what's going on in remaining dysfunctional cells. One new thing that we've learned about antidepressants is that almost all antidepressants significantly improve neuroplasticity and neurogenesis. This makes them remarkable compounds. There are few others, if any, compounds which actually increase neurogenesis, and people are experimenting using antidepressants to try to treat diseases of the retina, for instance, to get neurogenesis active there, and other sites of the body. So and if you give an antidepressant which increases neurogenesis and neuroplasticity, if you block the neurogenesis, you don't get the antidepressant effect. So that for reasons that we don't yet understand, neurogenesis is essential for antidepressant efficacy. And so this leads us to a search for other compounds that promote neuroplasticity and neurogenesis for the treatment of depression, and in tissue engineering. One other thing that we know, which is disturbing about depression, is that there are systemic or total body manifestations. The pathological losses or gains in tissue in specific sites set into motion pathologic changes outside the brain. They're responsible for the premature onset of coronary artery disease, stroke, diabetes, and osteoporosis. So that depression is really the tip of the iceberg of a syndrome that is serious and systemically widespread. Patients with depressive illness lose approximately 7 years of life. Much as untreated hypertension predictably shortens the life. Now I'm going to talk a little bit about CRH, which is the main driver of cortisol. It actually does many things in addition to driving cortisol, and I don't think is the core abnormality in depression, but it confers many of its observable features. If you give it centrally to experimental animals, it induces fear-related behaviors, anxiety, and increased vigilance, inflexible mood and cognition, the hypercortisolism, and increased norepinephrine secretion. It produces the insulin resistance, the pro-inflammatory state, and increased coagulation. And it inhibits food intake, sleep, sexual activity, and the endocrine programs for growth and reproduction. Now, here's a study that we did that was sort of an ambitious study to really get a good picture of this, where we put lumbar drains in where you would do a spinal tap and left them there for 30 consecutive hours. The neurosurgeons do this after almost all neurosurgical procedures. The incidence of infection is virtually nil, and there are virtually no side effects. And what we saw is that cortisol was elevated around the clock in the upper left, even while people slept, so that this anxiety and hyperarousal does not require consciousness. And in the lower right, you see I have this reverse. You see that CRH is significantly elevated around the clock in patients with major depression, including when they are asleep. Now, I mentioned norepinephrine before. Norepinephrine has many of the same effects as CRH, and it induces fear-related behaviors, inflexible mood, and so on. Activation of the amygdala, increased blood pressure and pulse rate, the insulin resistance and pro-inflammatory state, increased coagulation, and it inhibits the neurovegetative programs. And in that study, when we took exfused CSF for 30 hours, this is what we found. The first thing that we found, this is a picture showing the 24-hour levels of norepinephrine in the cerebral spinal fluid, and it's elevated around the clock. And the slide below shows the restoration of normal secretion after electroconvulsive treatment. And electroconvulsive treatment seems to be very draconian, and we try to avoid using it. But actually, if we had, say, an 80-year-old person who had become very depressed and had stopped eating and was wasting away, and we wanted to get a rapid antidepressant response before Dr. Zarate came along, we would use ECT, and it would work in over 90% of the cases. This is the curve in red of the 24-hour norepinephrine secretion in plasma, and it is restored to normal after ECT. And here is the 24-hour pattern of cortisol, and its level comes down after ECT as well. The top three show you curves that are virtually superimposable. These are all cardiotoxic compounds. And when they peak early in the morning, near the right end of the slide, that is a time that occurs that is the maximal time for susceptibility to heart attacks and to sudden death. And here is epinephrine or adrenaline, which is elevated around the clock and only is partially restored after ECT. This is a study we did in another group of depressed patients who were not as severely depressed, and we put a cannula in an artery and infused radioactive norepinephrine so that we could get calculation of its disappearance rate. And this gives us the spillover rate. And you see in melancholic depressed patients, the baseline is elevated. They get an increased response during a video game, which is a mild stressor, and a rather substantial rise after yohimbine, which is a drug that increases norepinephrine secretion. So both CRH and norepinephrine are activated, and they synergize with one another. They stimulate each other's response and each other's activities. Now, I mentioned earlier the systemic manifestations of depression. And the pathophysiology is essentially what I've shown you before. The inflammation that is part of depression is very much a part of this pathophysiology. Coronary artery disease is principally an inflammatory disease, and the major marker for coronary artery disease, CRP, which you get drawn in your doctor's office, is an index of the cardiovascular risk. And if your level is over 2, you're at somewhat high risk. Over 3, at greater risk. And CRP is an inflammatory marker because the atherosclerosis is largely due to an inflammation of the veins, of the arteries. Increased cortisol secretion has a multiplicity of effects. Every cell in the body has a cortisol receptor. The sympathetic nervous system activation, the insulin resistance causes much physiologic morbidity and the increased clotting. Let me show you some data that we've done looking at insulin resistance. I'll describe insulin resistance a little bit. I hope that this seems clear. Insulin is a hormone that's secreted that causes glucose to exit the bloodstream into the cell. And if you lack insulin, you have diabetes, And so blood does not get into the cells, and instead it builds up, and you have very high blood sugars. During stress and in depression, we get slightly insulin resistant. So that what happens is that the insulin doesn't really promote as much glucose transport into the cell. It builds up in the blood supply, and high glucose levels go to the brain, which doesn't need insulin to transport glucose across the neuron. And for that reason, insulin resistance is a clever way to increase plasma glucose acutely and to promote optimal brain function during stress. And we see that in our depressed patients who are remitted, they're not depressed any longer, they have increased plasma insulin levels. The insulin is going up and up trying to get the glucose into the cell. It doesn't manage to do it completely. And the plasma glucose levels are elevated in patients with depression. They're not abnormally elevated. Insulin levels don't get abnormal until 100, 110. So here it's in the 90s or low 90s, but it's significantly higher than we see in healthy controls who are matched for BMI, age, and gender. Then we see elevated fasting triglycerides and total cholesterol in remitted patients with major depression. They have high triglycerides. They're not outside the normal range, which is about over 160. They have high cholesterol, not outside of the normal range, but it's 185 compared to the total cholesterol in very closely matched controls. And next, there's a compound called adiponectin, which is very essential for insulin sensitivity. I won't go into this in detail, but adiponectin promotes insulin sensitivity, and its levels are reduced completely in patients with major depression around the clock at every time point. One of the things that happens during depression because of high cortisol levels at the top of that sphere, high insulin levels, high IL-6, which is promotes inflammation, and that increases the accretion of adipose tissue, but a special form of adipose tissue, which is intra-abdominal. We call it visceral fat. And visceral fat is a very active biochemical machine. And on the right there, you see it makes a variety of anti-inflammatory, of pro-inflammatory compounds that cause inflammation. IL-6 and IL-6 soluble receptor. You don't need to know these, TNF-alpha, resistant, and so forth. And actually, the levels of the circulating pro-inflammatory compounds correlate with BMI. So if you have a child who's moderately overweight, they're in a pro-inflammatory state. And anyone who is overweight or obese is in a pro-inflammatory state. And that confers a lot of the morbidity that goes along with obesity. Now, insulin has a variety of, it's elevated in depression, a variety of negative effects. It promotes inflammation and it stimulates the sympathetic nervous system. It produces bad lipids and it increases clotting. Now, this is some studies we've done. There are many others done by others that show inflammation in patients with major depression. And the inflammation story in depression is very exciting, really. It's present in a very large percentage of depressed patients. It's present in the bloodstream with increased stimuli, compounds that stimulate inflammation, and there is increased inflammation in the brain. And this seems to precede the major depression. So some people feel that inflammation may be a primary trigger to depression, and some have used anti-inflammatory compounds, and with mixed results, but there have been several which show that they have antidepressant effects. This is an around-the-clock study we did with plasma IL-6, which is a pro-inflammatory compound. It's elevated around the clock in our patients. These are in patients who are no longer depressed and not on medication, and they have high levels, as you see on the right there, of CRP, this compound that predicts coronary artery disease. And they have high levels of something called serum amyloid A. There is peripheral CRH, which we've shown, that comes out of sympathetic nerve terminals, and it is pro-inflammatory. It stimulates white cells, and it stimulates a cell called the mast cell, which contains, it's a bag of pro-inflammatory compounds that can do great harm if uncontrolled. Skip that. And IL-6, one of the pro-inflammatory compounds, has a whole variety of other effects. These things all influence one another. They're synergistic in their actions. They are positive feedback loops. Nature has really designed the system so that you can really get the stress system ramped up in a dire emergency. But I think that provides the context for there being so much depressive illness, because depression apparently affects 16% of the American population at one time during their lives. Now, why might patients with major depression be inflamed? This is speculative on my part, but there is a new form of inflammation which has been described called parainflammation, and it occurs in the context of stimuli to which we were not exposed in our early evolution. And so we become inflamed in these contexts during an old age, which was not present long, long ago, during overfeeding or obesity, in underactivity, with disruption of the ordinary light-dark cycle with artificial lighting, with synthetic chemicals and drugs, and so forth. And I suggest, again, speculatively, that major depression may be a parainflammatory disease, because early in our evolutionary history we may not have experienced the everyday multiple small stressors that are incurred in our everyday social interactions or living in crowded conditions. There are several markers for parainflammation that we're looking for to see if we can verify that this process is transpiring in patients with major depression. And in coagulation, we see the patients with major depression have increased plasma fibrinogen, which is a clotting factor. And the next slide, I won't dwell on these, but just to show you again that both in the morning and the evening, patients with depression have increased clotting factors. One is called Pi1, and the other is called factor 8. We reported in the New England Journal of Medicine that even premenopausal women with major depression have osteoporosis. And here's a schematic slide of the hip. And if you look at that nomogram, you'll see that the darkened area is the normal range, and this patient is way down in the osteoporotic range, and this is a 35-year-old woman with major depression. Now, they don't get fractures because of their youth. The protein buttressing of the bone is very strong and intact. But as they age, they become progressively more susceptible to osteoporosis, or its precursor, osteopenia. These are the bone mineral density markers at various sites. They're all reduced in the depressed patient in multiple sites in the hip and multiple sites in the spine. This next slide are, the first is osteocalcin. It's a compound that promotes bone growth, and it's reduced in depressed patients. And there's, on the right side, there's something called deoxypyridinium links, cross-links, which go up when there is bone production, and they are reduced in patients with depression. Here is a biopsy that we did in one of our more severely osteoporotic premenopausal women. On the left is the normal architecture of the bone. there are what we call trabeculae, or canals. Oh, yeah. There are trabeculae, or canals, that are made of tough material that suspend the bone and give them a strong matrix. And in the osteoporosis of patients with major depression, that structure is markedly disrupted. I'm going to just mention something about atypical depression. I don't have enough time to show you the data that we have in it, but atypical depression is another form of depression. It affects another 30 to 40% of patients with depressive illness. And in contrast to melancholia, which is a state of pathological hypoarousal, atypical depression is characterized by profound lethargy and fatigue. The patients feel much less alive than usual rather than anxious. They also have a decreased capacity to experience pleasure. Instead of losing their appetite, they have increased appetite and weight gain, increased sleep. Whereas in melancholia, the depression is worse in the morning and gets a little better in the evening. In atypical depression, the severity is less in the morning and more severe in the evening. And the patients feel walled off from themselves and others and state that they feel a painful loneliness, which is hard to escape, even when they're around other people. And we've shown that these patients have low stress hormone levels, have increased indices of inflammation, they have decreased activity of the growth hormone and reproductive axes, and they have increased heart disease. I'm going to close just with a concept that people are becoming more interested in, and I think we'll have more biological markers for in the next few years. But it's the concept of resilience. The American Psychological Association defines resilience as the process of adapting well in the face of adversity, tragedy, trauma, threats, and even significant sources of threat. And what confers resilience? There are genetic factors. If in identical twins, if one has PTSD, the other twin has a 40% chance of having it. So even though they share 100% of their genes, there is not 100% of concordance. So 60% of it is environmental. Repeated childhood trauma to uncontrollable stressors. And people did a study of children who were housed in institutions, and those who were adopted later, they studied them, they were more anxious, and they did brain scans on them, and they had amygdalae that were increased in size and activity. On the other hand, mild to moderate controllable stress early in life can have an inoculating effect. Such experience leads to increased neuroplasticity and neurogenesis and increases the size of the subgenual prefrontal cortex. An enriched, nurturing environment in early life with exposure to manageable novelty increases resilience later in life. Positive emotion, optimism, loving caretakers, flexibility, the capacity to reframe adversity, and strong social support also increase resiliency. And finally, altruism, a commitment to a valid cause, a capacity to extract meaning from adverse situations, and a tolerance for emotional pain and sadness promote resiliency as well. And people are developing a panel of biomarkers for resiliency that hopefully will be validated in the years to come. So I'll stop at this point and take questions. Okay?
I'm not sure I actually understood some of the charts and things. That when you're talking about a depressed person and then a non-depressed person and compare things, did you have a depressed person and then a depressed person who, after treatment?
Most of the depressed people we study, we hope to study while they're not on treatment, so that the studies are not confused by the impact of the drug. So all of the patients that I showed you were people who were depressed but medication-free.
Oh, all right.
Well, in response to the last question, I'm a little bit puzzled by the definition of depression. Is there a neurobiological correlate that enables you to identify it, or do you just go by patient's report? Is it just that the patient is seeking treatment? I mean, I look for lessons in your account, and it seems to me one of the lessons is we ought to be taking antidepressants because it's going to improve our brains. And I'm sure that's not what you intended.
Yeah.
But it would be nice to know what exactly is the working medical definition of depression, and then the correlate of that is there a precise neurobiological correlate in a sense that with runner's highs, we know it's enkephalins and endorphins. What is it for depression?
Well, but with runner's high, the same problem with runner's high, there is overlap in these abnormalities between depressed patients and controls. They're not completely separated. So we don't have what is a definitive biomarker. And that is, I think, one of the most active areas of research in depression research. They have many abnormalities, that is, levels of things that are higher or lower, systems that seem to be going awry together, and complications which make sense in terms of those abnormalities, but not a definitive biological marker, which I think will be the holy grail. And I think it'll probably be a genetic marker.
Okay, so why shouldn't we take antidepressants for neurogenesis?
I don't know.
Well, I got a lesson from you then.
Thank you for that. In addition to genetics and childhood trauma, I'm wondering to what extent environmental factors like air, food, etc., play in the development of depression.
Yeah, I don't know if there are any data about environmental factors like air. There are scattered reports of poor diet being one predisposing factor to depression, with a number of other factors involved, but they're not real systematic studies of these kinds of environmental factors. There are more studies that have to do with adverse psychological and physical environments for children and so forth, and adults. Yeah, yes.
Thank you, Phil. That was a really interesting talk. You seem to, well, more than suggest, we are stuck in an evolutionary loop in the sense that we are living with a system that is wired for a primitive time.
Yes.
And, you know, there are, of course, in the evolutionary trajectory, we have lost hair, we have increased our head size, we've done enormous advances to adjust to our modern lifestyle. How can you speak to the fact that this is one place where the human body has not evolved?
It's a very good question. I don't know, because the anxiety is so necessary for survival, and we're so surrounded by stressors, and especially early in our environment, but even now, that I'm not sure there have been mutations that weaken the stress response that increase survival. But I don't have a really good answer for that. But it's true. We've evolved in some ways, apparently not in this way. Yes.
You pointed out that depressed people have increased insulin resistance and other markers that normally would lead to obesity in depressed people. So, but medications also get blamed for causing weight gain. So
Right.
if you don't treat a patient, then they're going to gain weight. So which is really the better way to go?
Right. The insulin resistance usually occurs in the melancholic patients who are also lose their appetite, so they don't become obese in that regard. And some antidepressants do cause weight gain, but newer antidepressants are coming along that don't have that side effect, but there are serious side effects of some antidepressants.
This goes back to the first question, and I'm not sure I fully understood the answer, so I'm going to press you a little on this. If I understood correctly, you have characterized depression as a progressive disease and not a simple biochemical issue. You have described different kinds or variations on the theme of depression, the different kinds of depressed people. The phenomenon I'm most interested in is the confidence, scientific confidence, that can be expressed to capture this in that way. That what I'm getting to here is the indicators and the extent to which they are definitive markers for depression. And what's behind the question is in the experience, and I suspect I'm not the only one who have people with depression in their family, but there's a large part of the family that rejects depression as a disease or a physical illness and instead looks for a character weakness. And if there were a definitive scientific marker, that would, I think, help in terms of reactions.
Well, I think that there have been longitudinal studies, neuroimaging studies, that show that the loss of volume of that subgenual prefrontal cortex is progressive over time, and that the changes in the amygdala are also progressive over time. There are also some data, this doesn't apply to every depressed patient by any means, but there is an epidemiological sense, especially with recurrent depressions, that the disorder gets worse over time. The episodes are more severe, they come closer together, and rather than requiring an environmental precipitant, they occur autonomously. But I think those are the data that we have. But I think that given all the imaging data, the physiological data, the responses to pharmacological treatments and so forth, the fact that it's and the systemic disease that patients with depression get, that it's fundamentally incontrovertible that it really is a systemic disease. The World Health Organization recently had an international conference where they decried the propensity for people to see depression as a personal failure in view of the incontrovertible data about its biological roots, and urged more money for research and treatment facilities to treat it. 60% of depressed patients in the United States are untreated. Yes. Please.
You mentioned at one point that in terms of a certain type of depression, anxiety is the cardinal manifestation. So I'm wondering, what is the difference between an anxiety disorder and depression, which has anxiety as its cardinal manifestation?
I think, they both respond to similar medications. They have some genetic roots in common. I think there's an overlap. One of the things that is absent in anxiety disorders is the upsetness with itself, the feeling of worthlessness. People with that kind of anxiety disorder are more worried about accidents, things happening that could harm them, and so forth, or coming down with certain diseases that can shorten their lives, but not this anguish over the state of self that is the cardinal manifestation of melancholic depression. Anxiety disorders generally are not associated with alterations in appetite or sleep and some of the other neurovegetative findings. They don't necessarily have increases in secretion of cortisol and norepinephrine. They're generally normal in patients with anxiety disorder. But there is a genetic and clinical overlap. That's a good question.
That hopefully will go away on its own. But is there current research that we can learn from? Like, how long is too long to have situational depression, and if it might turn into major depression, and should we run for treatment after a certain time period?
Well, the diagnostic criteria say only after 2 weeks of major depressive symptoms, but ones that are really severe. Early morning awakening, loss of weight, loss of appetite, terrible upsetness with self, relative incapacity, and so forth. So they say that really after 2 weeks, but I would watch longer than that. But I think if something went on for a month or so, I would begin to feel concerned about it. That one issue is there used to be the idea that if there were a situation that caused the depression, it was not biological. I don't think that's the case. I think stress often precipitates depression, a loss in the personal realm or of a loved one, and people can become depressed and remain depressed after those losses. It should not be considered that they are impervious to depression, but are merely sad if they really show all the manifestations of a depressive disorder. It's the phenomenology rather than the precipitant, I think, that matters. Yes.
Thank you. Just as we have public awareness on drugs, STDs, from your lecture, I'm beginning to think that we may now be at a stage in which we have to mount a public awareness on this.
I think that's right. The NIMH is mounting that, but it has limited resources. But I think that over time, and as the new findings are coming out, more neuroimaging findings, the kind of findings that Dr. Zarate has with immediate responses to new drugs, and genetics, I think will capture the imagination of the public and make it clear that it's a serious disorder that's progressive and needs to be treated.
I'm a psychotherapist working in East Tennessee with children, adolescents, and adults, and I was particularly interested in your brief tour of resilience and children. And when you're working with children who have not necessarily had that resilience, perhaps have reactive attachment disorder, is there research being gone on? Are you doing some things about how to help a child get resilience if they don't already have it?
I'm not an expert in it. I've read some papers, and there are strategies to develop resilience, promoting challenges that are manageable with the supportive assistance of an adult, and reward and progressively increasing the challenge and systematically going ahead like that. Yeah. Okay, one more question, I think. Yes.
Sir, perhaps this is appropriate for the last question. What is the state of the art in repairing the brain from this disease? What can we do? What do you expect we'll be able to do to repair the neurology that's the genesis of this?
There have been two efforts to do so-called psychosurgery, implanting electrodes in treatment-resistant depressed patients who have had terrible and completely treatment-resistant depressed patients. The insertion of an electrode and stimulating the subgenual prefrontal cortex produces immediate and sometimes lasting response. And also there have been electrodes that have been placed into the reward center, and stimulating the reward center also seems to produce an antidepressant response. I think people are working on all kinds of ways of trying to influence brain activity without being invasive. There are now magnetic resonant treatments for depression. Some people even say that MRIs are helpful for treatment with depression, and other non-invasive ways of affecting affected brain areas. As we learn more about the areas that are affected and find others that may be larger and more amenable to external manipulation, that may be new strategies for treating depression that way.
Do you believe we will actually be able to repair ourselves eventually?
It's a good question. I think that we will know enough about cellular repair and neurogenesis and other factors that that repair would be possible. Also, psychotherapy is very important in treating depression, and the best treatment for depression is a combination of psychotherapy and medication. And that is by far more effective. And there have been data that show that people who have successfully responded to psychotherapy have positive changes in the subgenual prefrontal cortex and the amygdala and the ventral striatum. So experience can also modify the brain. Thank you. Our next speaker is Dr. Carlos Zarate, who runs a very large laboratory and research program at the NIH Clinical Center, looking for new and rapid antidepressant treatments. He's made what I consider, and many do, consider the most important discovery perhaps in the last 25 years in studying depression, and that is the capacity of ketamine to induce a remission in treatment-resistant depression, patients with depression in as little as a half an hour, and sometimes lasting for days. And I know he's just published a paper that actually has discovered other compounds that can do this even better, that they're attempting to develop and synthesize to treat depression. And anytime you get an effective treatment of depression, you also have a tremendously important tool for figuring out the mechanism of the depressive syndrome. If you know what the drug does, and it makes people better, then you learn something about the underlying disease. So I'd like to call Dr. Zarate, who will review his experience with this very promising field.
Good afternoon. Thank you so much, Dr. Gold and others, for inviting me here to speak of our work. And I have a series of cartoons and animation. Hopefully we'll summarize our work and make it understandable. And at the end, I'll be glad to take questions. So the title of today's talk is Relief from Severe Depression and Suicidal Thoughts from Within Hours, and our work going from synapses to symptoms. And most recently, 2 candidate drugs that can actually accomplish this rapid response. This is my disclosure. I'm a full-time employee in the federal government with the National Institute of Mental Health. So briefly summarizing, mood disorders are common, chronic, and recurrent. We have major depressive disorder and bipolar disorder. Our next speaker will go more in detail into bipolar disorder. But it's not only presents itself as manifestations or problems of mood, but there's problems of behavior. Now circadian rhythms and activity levels is crucial. We'll see problems with excess activity levels during mania, in decreased activity levels during depression. And why is that? Well, if you ask our patients or their family members, it's very hard to recall in the past states of elevated energy and mood based on subjective report. What is very easy or easier to recognize is when they have increased activity levels that they can go on and on, our patients for hours without sleeping. Now it's not viewed as Dr. Gold mentioned simply as neurochemical disturbances, but the mood and the behaviors are and circadian rhythm disturbances are the result of disturbances of synapses and circuits. But these synapses and circuits, of course, have influences from genetics and environment as well. Now, we have generally a negative in mood behavior has been reported. Most of our patients have both depression and anxiety at the same time. There is irritability. Many of our patients are very angry and hostile, and that's unfortunately a concept that has been lost over the years in terms of what you see with your patients is really that. There's hostility and risk of violence and suicide. There is also the opposite extreme, which is the manic mood and behavior, where you have excess energy levels, activity levels, and increased risk-taking behavior. I'm not going to get more into that because our next speaker will. But towards the right, you see an image of the same person during their state of depression, sitting still, looking in the distance, probably have a poverty of thoughts, thinking probably of death, not eating, not sleeping, and that's generally what you see in the same woman at the opposite extreme, where you could see probably dressed with many layers of clothes, giving belongings away, so on and so forth. Our patients can have also psychotic symptoms or cognitive symptoms. The psychotic symptoms are impaired reality test, and and cognitive symptoms, distractibility, and impaired cognition. And what's very interesting in our patients with both depression and with bipolar disorder, you can have a mixture of any of these symptoms over the course of your life. And one episode is not necessarily the same as another episode you may have had 30 years, which makes it very difficult to diagnose our patients accurately. Now, we talk about symptoms and categories, but this is a real patient, one of our patients on the research unit here in Bethesda. This is Bob, 53-year-old married male with a 35-year history of severe refractory major depression, comorbid anxiety, phobia, PTSD, and alcohol dependence. Has had 10 major depressive episodes. Mother had anxiety disorder. Brother had a history of depression and alcohol abuse. He, very smart, went to school, the best schools, got a BS, was running big, prominent organizations, had a suicide attempt with overdose of nortriptyline, that's one of our treatments, or Pamelor for depression, and nearly died, was admitted to our hospital with thoughts of stabbing himself with a knife or driving off a cliff with a car. I'll come back to Bob later on. Now, it's been mentioned before, these are very commonly associated with many conditions, other psychiatric disorders if you have depression, but they're very impairing in terms of the amount of disability. This is a rank order list of the conditions or disorders that are associated from number 1 to number 7 of those causing major disability. And you can see what is at the top. Neuropsychiatric disorders. We have mental and behavior disorders, much more than neurological disorders. But this group of categories are much more disabling than cardiovascular disease, musculoskeletal disease, diabetes, and so on and so forth. And remember, these are chronic disabling disorders of the young. As already mentioned before, cardiovascular disease starts later in life, but you have deprived and robbed our young ones with having these illnesses. They have not been able to date, finish school, be able to buy their house, get a job, and so forth, and they start with disabling symptoms. So we have to do better. These are and not only is it associated with significant morbidity, but significant mortality. These are lethal illnesses. If you look towards the left, this is the peak, 1965 to 1995, peak percent of the illness, and what's happened with treatments over those decades, and how it's affected the prevalence or the rates of these illnesses over time. And you can see, in general, leukemia, all leukemia has gone down with new information on terms of pathophysiology, new treatments, so on and so forth. We're doing a good job there. And also in heart disease, you can now decrease 1 million deaths per year with exercise, diet, better medications, and treatment. We've also made progress in AIDS. As you know, people can now live into very late years of their life with treatments. And also stroke. We can now, if you show up to an emergency room within 2 hours, 1/3 of there can really have a good outcome. So very important, if you have symptoms of stroke, go to the emergency room right away. However, look what happens with suicide. Despite 50 years, 30 to 40 different antidepressants. The rates of depression have not decreased, and for suicide has not decreased over the years. In fact, if you think of a measure of success as decreasing the rates of serious mental illness, despite all our treatments, we've not made a significant dent. In fact, the suicide is wrong. In fact, there has been an increase. Recent reports show actually there's been a 24% increase in suicide. That's a major issue, and I'll talk about a little bit later. Not only do you die because of suicide, but the excess deaths are due to other factors. Many of what Dr. Gold has mentioned, problems, pro-inflammatory conditions, coagulation, hemostatic conditions, so on and so forth, there's an excess risk of death from cardiovascular disease, from suicide, and from accidents. So our patients with mood disorders, particularly bipolar disorders, die at younger age. It's not unusual to live 10 to 20 years less if you have a major mood disorder. And I already mentioned, you start already with significant disability from young age. Now, this summarizes a little bit what Dr. Gold was talking. This is the course of illness. You have in the upper left corner a diagram showing in the blue major depressive episodes, yellow are the well-being or euthymic intervals, and then in green are the hypomanic or manic episodes. And generally, for a significant number of our patients, as time goes by, your depressions last longer. You can see in the figure, they're more severe, and the good times or the well-being is shorter and shorter, the yellow you can see. Each of those episodes have a significant impact. We already talked about the significant impact on bone, on brain and heart, and so on and so forth, but you can see the personal disruption to one's life, personal, family, occupational disruption, significantly affected with each of those episodes, as well as economic well-being, society is affected, and then there is the risk of suicidal behavior. Towards the bottom, you can see how problematic our disorders are. But it's even made worse that most of the time you do not find bipolar disorder alone. 90% of the time you find some other comorbid psychiatric syndrome or disorder. 70% of the time you have 3 or more psychiatric disorders, each sometimes requiring different types of treatment. Towards the upper right, you see a figure looking at the time of this study was about 120 patients with bipolar disorder that were followed for 13 years. And you can see in the bars is the percent of time in weeks that they have been affected. Half of the time of that 13 years, 6.5 years, they spent in having symptoms of the illness. Half of the time. 1/3 of the time was in depression. The killer and the big problem of our patients with bipolar disorder is the depression. In about 5%, they had rapid cycling or mixed forms of the illness, having both high and low at the same time. Now, each episode causes that significant social individual disruption, but it has the toll on the brain. And we talked about, has already been mentioned, towards the bottom right are neurons, the dendrites and the branches. There's atrophy and shrinkage of the spines, those places where you have connection from one circuit to another. In this diagram, you can see here that there's in the bottom right, a little circuit, and that, if it's intact, might explain why our patients have different symptoms. Dr. Gold and I may both meet criteria for major depressive episode, but we overlap on only one symptom. That's very common and very possible. So depression, and people were asking of a definition, is hundreds of disease. Hundreds, each with its separate etiology. So you can see how the clinical presentation might vary from him to me, and so on and so forth, depending on the circuits that are affected. We see that, for example, here the circuit is missing or it's affected, and you have anhedonia, lack of drive and pleasure, very common problem in our patients. And another circuit might be affected, and you have suicidal thoughts or, in fact, suicidal behavior. So towards the upper left, we see the spines and the circuits are very intact. It looks like a tree in spring. We have branches and leaves that can absorb the moisture and the rain and propagate the neurochemical signal. Unfortunately, because of the cortisol, as mentioned by Dr. Gold, the excess glucose and glutamate I'll talk about, it looks like a tree in winter, deprived of the branches and the leaves that can't absorb the chemicals, the moisture or the neurochemicals, and propagate it downstream. Towards the right, we see that there are many possible explanations for the shrinkage or atrophy of those branches. So it looks like a tree in winter. We have, towards the bottom right, we have BDNF, brain-derived neurotrophic factor. Those are the miracle grow factors, which you have in your garden and make things branch out. There are also these natural endogenous brain chemicals that maintain the neurons in the branches healthy. And you have the cortisol and stress and so on and so forth. So the different mechanisms. The one I will talk is on the right side of the figure called glutamate. Glutamate is an excitatory amino acid, and its regulation seems to be important to depression. So we talked about, we have, and people have talked about criteria. We have what we call a DSM, Diagnostic Statistical Manual, and that has been one way of how we communicate with each other, with families, our patients, and with clinicians on our patient who's in front of us. So it is a common language for describing psychopathology. In general, we do a fairly good job describing and agreeing that this person has a major depressive episode. There, unfortunately, is a significant overlap in symptoms and syndromes. I already mentioned how there's 40 to 50% of our patients have many comorbid psychiatric disorders. And the symptoms, unfortunately, do not map onto the brain. And so that has been one of the reasons why we have not been able to find more effective treatments. And so what has been proposed at the National Institute of Mental Health and IMH is to break it down into the more simple, more simple elements: anhedonia, motor activity or drive, suicide. In those strands, you can then understand it in a better way. Going into units of analysis all the way, for example, in anhedonia, from the behavior, lack of drive and pleasure, staying in bed and not enjoying things, all the way to genetics, going through circuits and cells, and that will give us a better understanding of these illnesses. And RDoc does focus on understanding the more simpler elements that go across many of these disorders. You can have anhedonia and panic, in obsessive compulsive disorder, and in depression, or in schizophrenia for that matter. Now, what do we need new treatments? Well, okay, there's 30, 40 different antidepressants, and this is the time course of discovery from the 1950s. And we started, the first antidepressant was discovered by serendipity, and that's unfortunately what happens in psychiatry. Clinical observation, which is a good thing, and I think will lead to continued discoveries, is really the only way we've come up with better treatments, just by observing our patients being exposed to different medicines out there. The first was a drug, an antibiotic given for tuberculosis. It was given at high doses, and they noticed the patients were dancing in the units and enjoying themselves and talking a mile a minute and not sleeping. And so then people thought, oh, this, you're high, that means it's probably good for your depression, and started coming up with different forms of it, known as the MAO inhibitors, monoamine oxidase inhibitors. And then the next 50 years, it was trying to go, well, the first few drugs were non-selective, affecting serotonin, norepinephrine, dopamine, choline, cholinergic systems. And people said, industry said, oh, they're not well tolerated and they're very lethal in overdose, like nortriptyline, like Bob was taking, Pamelor. So let's go to more simpler antidepressants that affect predominantly serotonin, you know that as the SSRIs, Prozac, Zoloft, Paxil, so on and so forth. And then some of the clinicians out there and patients said, well, probably they're not as effective as the older one. Okay, let's go back to two dual reuptake inhibitors, two neurotransmitter SNRIs. And then now there's going back to triple reuptake inhibitors. So most of drug discovery has been about Me Too drugs. They're pretty much the same, serotonin, norepinephrine. Most of the patients probably do not benefit much more than what we have from existing treatment. So they are suboptimal. And clinicians, patients, and families said, well, probably our medications are not effective, and so that effective or effective for some, let's figure it out. So NIMH did do this very large study called STAR-D. And it was a systematic way of giving levels of care. Everybody at level 1 started with the first antidepressant, citalopram, for 10 to 14 weeks. If you didn't respond, you went to the next for 10 to 14 weeks, so on and so forth. Okay, what we see is in the first bar is that about 33%, 36% achieve remission. Remission means doing very well. But it took 10 to 14 weeks. Move to the second bar, 50% achieve remission, but that takes about 6 months. 2 antidepressant trials for half of our people to achieve remission. That's way too slow, in my opinion. And then after 4 treatments, including psychotherapies I didn't mention here, 1 year later, only 1/3 are still not achieving remission, 1/3. And not only that, of those who respond in the beginning, 40 to 60% in those first two bars are relapsing. So what we see is low remission rates, a significant lag of onset, personal social problems, and the risk of killing yourself if the medication is not working or the therapy. Okay, this is drug discovery for those who are interested in the economics of it. This is how we develop drugs. Okay, we come up we have preclinical and clinical phases. This takes about 15 years and $4 to $11 billion, studying 10,000 compounds to get one. Possibly that might make it to the market. Okay, and these are the success rates. Infectious disease, the highest. Why? Because we know what the targets are. Okay, the lowest are what? Brain disorders, because they're complex and we really don't know what the exact targets are. The success rates for CNS is about 8% after spending all that money. And you can see why industry has been leaving psychiatry altogether. Now, this is a summary of why we need improved therapeutics and what happens. In this cartoon, you see in blue the depressive episode. We start our antidepressant. Okay, any of them currently on the market, it takes about 10 to 14 weeks. They affect monoamine systems, which is serotonin and norepinephrine. That's what I mean. Our goal is to shift this curve towards the left so that the next generation treatment, we will have treatments that work in a few hours, that wipe out your depression, your suicidal thoughts. And if you remember that time I showed the figure over your lifespan, how much time you spend in depression. Imagine for each of those episodes, which range from 4 to 9, average number of episodes for each patient, or half of the time you spent ill in your life, within 1 to 2, 3 days, if you have symptoms of depression and you treat that, it goes away. And the next one that comes goes away. You can imagine the cumulative number of episodes, or cumulative depression over your lifetime will be very short. Thus, your health, physical, as Dr. Gold said, will be better, and your brain will be better. So that is the goal of our program, is to develop rapid-acting agents. We come up with targets, in this case, glutamate. Our studies are what was mentioned, drug-free, double-blind, placebo-controlled on our inpatient unit here a few miles from here. And we study multiple biomarkers, both peripheral blood measures and brain measures at the same time to better understand our patients. Our patients are great, and they really spend, altruism was mentioned, they're really altruistic and really want to understand these diseases and help others to come up with better treatments. So towards the upper right, you see that we are looking at interventions that cause rapid antidepressant effects, such as ketamine, and an anesthetic I'll talk about, scopolamine, that's for seasickness. We're also looking now at neurodevices, TMS, electroconvulsive therapy. So our studies are double-blind, placebo-controlled, and what we do is at the beginning, we obtain multiple biological measures, and what we try to do is link these with our traditional rating scales of depression, which are not good, but it's all we have at this time, and we obtain responders or non-responders. The goal of this is to link the biological measure, whatever that might be, with our depression scores to see who's a responder, non-responder, so that we can come up with more biologically enriched subgroup. I already talked about depression's hundreds of diseases. This strategy will lead to a more enriched group to really tease out what is the etiology of these illnesses. And not only that, we obtain these biological measures before, during the study, and after the study. And I'll give very brief examples about that. That rather than focusing on what is the cause of depression, because we talked it's hard, hundreds of depressions, we're going to figure out what is the mechanism of the response process. Who responds and not responds. And why is that important? Well, response is probably going to be more similar across individuals than depression, and at least that's the belief. So one area to look at is the glutamate system, okay? And I'll talk a little bit about what this. There's evidence in postmortem studies looking at people who've had depression or who have suicided. There is evidence that some of the glutamate receptors are affected in the brain. And there's also evidence we use assays or what we call animal models of depression, animals that are stressed. And for example, forced swim test. You have animals in the cylinders, plexiglass that are struggle. That's viewed as a good sign, but when they stop struggling, that's viewed as helpless, as they've given up, and that's supposed to mimic depression. And I say, well, you know, you do that in a few minutes, but our patients have been depressed for 30 years. Is that a really good model? Probably not, but it's what we have been relying on for 50 years or so. But there was early evidence that our antidepressants affected our glutamate receptor called NMDA, and that's going to be very important as I talk about. In that if you give drugs that block that receptor, those animals that were made to be stressed and depressed got better. And so an early study done in the year 2000 trying to study cognition, because that's really affected our patients with schizophrenia, psychosis, and depression, noticed that the depressed patients got better. 7 or 8 patients got better within a few hours, and that was ketamine. And so we have done further work on that, and I'll talk about that now. Okay, this is a very simple diagram explaining the glutamate. Okay, glutamate are those little white balls there. We have 3, the top is the presynaptic neuron, the bottom is the postsynaptic neuron, and towards the right we have the glia. This is the tripartite system, important for regulating glutamate. Glutamate is an excitatory amino acid. It's very important for learning, memory, and the plasticity Dr. Gold mentioned. Okay? So it's synthesized, and it's stored in these little presynaptic vesicles, and it's released. And it's very tightly regulated. And it's believed that if the levels are excessive, that leads to neurodegenerative diseases such as Alzheimer's, Parkinson's, and in this case, depression. Depression might be more the regulation or the cycling of the system. There are mechanisms to control the amount of glutamate within that space, extracellular space. One is the EAAT, excitatory amino acid transporter, that grabs the glutamate and puts inside the glia, that's the cell on the right. And there's this metabotropic, mGlu, that's the thermostat, that goes up and down based on the temperature of the room, goes up and down based on the amount of glutamate. And then there's the postsynaptic receptors, NMDA and the AMPA. All this, the Miracle-Gro, brain-derived neurotrophic factor, that leads to the spine's very healthy trees and connections, is what the glutamate is important for, plasticity. And what happens in depression? The non-depressed, it looks like this, very healthy, we talked about, and in our depressed patients. Okay, so it's not so much about regulating glutamate, but even if you regulate dopamine, serotonin, glutamate, what is important is to have that tree healthy. And so our treatments have to be plasticity enhancers, make that tree go from winter to spring and be healthy. Okay, now, as you can see, it is a complex system. I tried to summarize it here, but there are multiple targets that one can pursue. We and others have been looking at that over the years. And this is just a summary of the studies. About 8 to 10 years ago, most of the companies had dropped out of psychiatry developing drugs, and we're just using off-label drugs, drugs that their patent had expired. Now, since the ketamine story, 2006 or so, many of these companies have jumped in to pursue drugs that regulate glutamate. Predominantly, if you look at the bottom, NMDA, that target is where everybody has been going over, NMDA receptor antagonist, through our studies and other studies. And I'll talk an example. The prototype drug is ketamine. Okay. Ketamine is an anesthetic agent that's been out for several decades. It's one of the most safest anesthetics. In fact, it's used in many countries around the world, even without a physician, nurses, in really remote areas, because it doesn't cause CNS depression, problems with breathing, and other complications that you might need a significantly trained anesthesiologist to manage. There are many drugs, I'm not going to go into detail, but if we understand ketamine, we can get a sense of where we were headed in our research. Okay. Now, that receptor I mentioned is blown up here. You can see this is the channel, ionotropic channel. This is one receptor where you have the sodium and calcium enter the channel, important for learning, memory, and plasticity. Okay, now in the channel you can see PCP. That is the drug called PCP. Ketamine is a derivative of that drug of abuse, PCP, but it's 10 times to 40 times less potent. It happens to bind to the same receptor. When it does bind to that receptor, the channel closes. And so while you receive ketamine or infusion, what is affected? Your learning, memory, and plasticity, right? Because we say that's important to the function of the channel. And you might say, why are we exposing our patients to these drugs that affect learning, memory, and cause symptoms of dissociation? Well, the important thing is, I'll mention that in a minute, is our patients are very severely ill. Now, when you block that channel with ketamine, you have psychological symptoms, decreased awareness, you might be disconnected, distractible, have trouble communicating while during the infusion. You stop the infusion and that reverts very rapidly within 30 to 40 minutes. You might have symptoms of out-of-body experiences, trails of light, muffled sounds, and your blood pressure and pulse might go up. Now, when our patients came, because we were interested in the question, if you block the NMDA receptor, will that bring about rapid antidepressant effects? Because this is the most available direct blocker of NMDA. And for that reason, we studied patients because of the side effects who were severely ill. And this is in our research unit a few miles up the road. Our patients had been ill for 24 years. Most were disabled, 90% were not able to work. They had failed 7 antidepressants, 60% have failed ECT, one of the most effective treatments. 50% of our patients had suicide attempts, some multiple. And so we really made sure they had failed everything, okay? And you would expect very little chance of responding, wouldn't you? Okay? And this is what happened in our study exactly almost to the date 10 years ago. And you see towards the left of these little lines on the y-axis, you see the Hamilton depression, higher number, greater severity depression. Towards the x-axis, you see the time in minutes and days. One infusion of ketamine, that's one infusion of ketamine for 40 minutes led to rapid antidepressant effects within 2 hours, lasting about 1 week with just in one infusion. You can see in red the control condition. Towards the right are response rates, means you are 50% better than when you started. To the extreme right, you see in light blue, monoaminergic antidepressants already mentioned. You get about 62, 65% response rate. But at 8 weeks, taking a pill every day in people who are not treatment-resistant depression. And if you look in green, is ketamine, response rate. You get comparable response rates within a few hours. That is the same as taking a pill every day for 8 weeks. But in people who failed, on average, 6 antidepressants. Something here. Well, what about Bob? Bob participated in a study. You know about him. 53-year-old, depression, 10 episodes, suicide attempt. This is what happened. Within a few hours, his depression and suicidal thinking was gone, and it lasted 20 days. Okay, with one infusion, drug-free, no other treatment. Now, I'm not saying everybody responds, but about 50 to 60% will have a response. So then the trick is, how do you go from something that you know that does work much more effectively, get rid of the side effects, get rid of the risk of addiction, because there's a risk of addiction, and continue and maintain a response. And we've made some progress there. Now, in the psychological sciences, one of the biggest problems, and also in other areas of medicine, is replication. Other labs cannot find it. Okay, if you look at the figures here, these are 2 other studies done by our lab. Depression scores, MADRS goes down within 1 hour, lasting a good part of the week. Another replication study showing exactly the same. What is very eerie, strikingly eerie is here, is the curves almost overlap, which is unheard of in psychiatry, especially with antidepressant treatment, speaks to a true biological phenomena that's going on and really a mechanism. People have moved on to, then after 5 of our controlled study, the NIMH decided to do a larger 2-site study, and you can see here exactly the same. Within 1 day, no earlier time points were obtained. Rapid antidepressant effects with ketamine lasting a good part of the week. More recently, Johnson & Johnson, and this study was led by Jazz Singh, who actually was my fellow in the first study but went to industry, decided to pursue this with Dr. Manji, and they looked at giving ketamine 2 times a week versus 3 times a week. If you look in the green dots, down means greater improvement, and then time over the next 2 weeks. So with repeat doses 2 times or 3 times a week, you bring down depression scores, and they still will stay well for at least 2 weeks. Now, the question is, how do you go about making a safer ketamine without the side effects that I mentioned, that it won't affect the brain, cause problems, and the risk of addiction. Okay. Now, Johnson & Johnson has gone the way of developing S-ketamine, one of the isomers of ketamine, in the hopes it's going to lead to and improve. And so if you see towards the top right, S-ketamine by Johnson & Johnson has received breakthrough designation. They are doing phase 3 studies and are planned to be on the market for 2018 based on the work we've been doing. So we're excited about that. People have jumped back into industry, but specific glutamate drugs, not drugs for all psychiatry. It's important to keep in mind. There are multiple grants being funded by NIH on this line of work, both preclinical and clinical. The second area is, can we develop more ketamine-friendly drugs? Meaning, ketamine, if you look at, is like this building. Okay, in this room is the efficacy, in some other room is the side effect. So that's what we call units or subunits. So how do you figure to get the drug in this unit and stay away, room and stay away from the other rooms or units? And that's the trick. Well, you can come up with more subunit selective drugs, and there have been some studies doing that, and I'll talk about that in a minute. So we have done a number of studies with these other more subunit selective drugs, and this is a summary of all those studies. Ketamine has rapid onset, robust effect, and sustained action. No doubt about that, but it has its side effects. Okay, Dr. Insel, who's no longer a director at NIMH, moved on, but summarized this after all our studies and others, and says that other medications that block these receptors are not antidepressants. Okay, I would say that's not the case. I would say they are, but probably not as robust and sustained as ketamine. I do think they have antidepressant properties, but they still have that side effect liability. Okay, in fact, this is a summary. We've done all these studies except for one of them, but we have, you can see memantine is for Alzheimer's disease, blocks that NMDA receptor, and there's others, MK, a drug by Merck, now Seroquel, then there's a Pfizer drug and AstraZeneca drug. These are the companies that went back in. And you can see some minuses, maybe a plus and minus. So bottom line, these drugs are not as robust and as effective acutely as ketamine is. And so that's another area we have to go into. So I think the other area we've got into is mechanism of action. So in what we call this is reverse engineering, okay? So we talked about how ketamine is very unique and different than other treatments. So, you know, why not science the heck out of this drug, okay? As I'm going to quote from a movie. And we can take advantage of our facilities at the intramural program. Okay, we have polysomnography, sleep studies, the ability to do neurochemical studies, look at glucose or glutamate in the brain. We can do magnetic encephalography. That is a machine that measures how one neuron talks to another neuron. We can do functional studies, structural imaging studies, so on and so forth. To understand, if you look at the bottom, everything that goes from genes, cells, circuits, all the way through symptoms to the RDoC criteria. If you can understand and fill in the gaps of knowledge, you might be able to understand how this rapid antidepressant works and develop other treatments. And we have done those studies. First of all, towards the top right, this represents rats that had measurements while they were moving around of glutamate levels. And you can see here, when you give an injection of ketamine at 20, 40, 60, 80, and 100 minutes, keep in mind those minutes. That's very similar to the response rates, time of response to ketamine, but this is in rodents. You see very quick increases in glutamate extracellular levels. So we did a study in the forced swim test in 2008, Dr. Manji, and this is the forced swim test. It's that little rodent that's struggling, and you can see in green ketamine, decreased in mobility. That means it has antidepressant-like properties. Towards the right, you see an AMPA blocker. Remember, next to the NMDA receptor was that other glutamate receptor called AMPA. And so here the study was looking if we pre-treat with an AMPA blocker, would that abolish the antidepressant effects of ketamine? Okay, because NMDA is blocked by ketamine. And the answer is yes. You can see towards the right in ketamine plus AMPA, the antidepressant effects of ketamine go away in mice. So it seems that those AMPA receptors are important, and I'll come back in a minute. Going back to those apartments or the rooms, subunit selective drugs in R2B antagonist, we see that it does decrease. The immobility means it has antidepressant-like properties, but also if you pre-treat with AMPA blocker, the antidepressant effects go away, suggesting AMPA receptors are important for the antidepressant effects of this compound as well. Now, here's a cartoon that puts everything together, what I mentioned. Okay, you have the presynaptic neuron and the postsynaptic neuron. Okay, so you have ketamine binds to the NMDA receptors, as we mentioned, on these GABA interneurons, another part of the brain. So the scopolamine, it's a seasickness patch, but here we give it intravenously, binds to its receptor on the same GABA interneuron. What both appear to have in common is this glutamate surge burst. I already talked about that increase in glutamate. That preferentially targets in yellow those AMPA receptors and causes this intracellular signaling cascade, similar to what Dr. Gold was talking about, and causes this increase in BDNF, brain-derived neurotrophic factor. Those are the growth factors that maintain the neurons and dendrites healthy. And so in this cartoon, you increase the number of spines, you restore the synaptic connections that were affected that I began talking about, and you restore that homeostatic balance that was affected because of stress, glutamate, and cortisol. And that's at least a prevalent theory. Now, this study is quite complex, but we have just finished where we obtain all these measures in our patients who are depressed to better understand the biology of the response process. And here they're listed, but the goal is to understand the neurobiology of the response and relapse process. And just to show, very similar, the study just finished is identical, the curve, to all the previous studies. Very rapid onset, people stay better for 1 week or more. Okay, and this is an example of some of the tasks we use that taps into those regions or circuits that Dr. Gold was talking about. One is you expose in anybody healthy controls or depressed patients faces. And faces will light up certain parts of the brain. The visual cortex, of course, the back of the head, occipital is one of the regions, and you will pay attention to the gender or to the valence, meaning happy or sad in the face, and you have to react very quickly when it's shown, and it's shown in milliseconds, and so it's supposed to be subconscious when you do this. And you can look to the left is the accuracy rate of being exposed to these faces. One is positive and before ketamine and after ketamine in depressed patients. And you can see the negative valence, the bias towards going to pressing the trigger, the button to the negative goes down. Okay. And towards the right, these are what we call evoked potentials. It's an electrophysiological measure of the visual cortex, taking into account the gender or the valence, that is happy or sad or angry face. And you can see here with ketamine, it increases the positive. So you start biasing your responses to more happy things, and the bias towards the negative, angry, sad things start going down, precisely what you want in depressed patients. And so this is an example of a non-invasive biomarker that could predict ahead of time who might respond or not to a certain drug. Now, to get into a little bit more complex, but I'm trying to make it simpler, is Dr. Gold talked about subgenual anterior cingulate cortex, ventral striatum, okay? And if you look into the figure towards the right, you see all those little regions lined up one after another. And this is what we refer to as a matrix of correlations, how one region correlates to another. It's now viewed as a bit simplistic to study one region in isolation. Now, what we try to do is to study one region related to another. The brain So one area of the brain is talking to another. So if you have a computer in your office, okay, and there's a problem with the computer, many times it's not the problem with the computer, that's one region, but it's the problem with all the network. Okay, you have networks of computer and you have a server, and that server is the hub of the networks. And so that's what we try to understand is not one computer at a time, but every computer at the same time, how one computer talks to another. And not only that, you can go from your building to the building across the street into the whole community. That's how we're studying now our mental illnesses. And this is referred to as functional connectivity, how one region talks to another. And these matrices you can see in the warmer red colors are positive correlations, they work in sync, and the lighter or cooler colors are how they work against each other. And you can measure this through functional imaging. This is to show towards the top is 101 represents one subject who received 5 scans during the study, 5 functional scans. And if you look to the bottom is at baseline, 2 days after ketamine. Why at 2 days? Well, we already said the peak of response is there. so you can understand the biology response. And then 10 days later, why 10 days later? Because I said the ketamine effects last about 7 days. So you're looking at the relapse. So here we're looking at the biology of the response, non-response process, and the relapse. So that's very, very important because you might be able to predict who will respond and who will relapse, okay, as an example. Okay, I should move on. Getting into some examples of anhedonia or lack of pleasure. I talked about we pull out the strings to better understand it. One example is we looked at lack of drive or anhedonia, and this is measured by the SHAPS. Ketamine produces a rapid decrease, stays down, and for about 2 weeks, people with lack of drive and anhedonia stay well. And this is measure FDG, fluorodeoxyglucose scan. That's a surrogate of glutamate function. And we can show here, towards the left, is the relationship or correlation between ventral stratum, that's the reward circuit, and glutamate levels. Okay? So the greater the bold signal, the better the response. And this area happens to be dorsal cingulate cortex. And finally, I'm going to get into the last 3 slides I hope I have, is the paper that came out yesterday. Okay, so this was, it was a clear, this is a collaboration by Maryland, Chapel Hill, and I mentioned several institutes, in terms of trying to understand the mechanism of ketamine, to develop a better ketamine. Okay, in this story, what I was bothered, you remember in green are the response rates, okay? The side effects go away in 40 minutes. The half-life of the drug is about 1 hour, so why is it lasting 7 days or longer? And so what we said is let's look at the metabolites. And older papers said it's inactive, some of them. Well, inactive for anesthesia, but they didn't know about depression back then. So we looked at all of them, a bunch of them, and now have come up with a candidate drug. So this is a cartoon, hopefully that explains the study, and I'll end here. Okay. RS are the 2 isomers of ketamine, okay? That's the chemical structure. Here, we give ketamine intravenously, okay? It goes to the liver, and within 10 minutes, you have towards the right, hard to see, but what was that? All those metabolites within 10 minutes in the periphery, in the brain. Okay, and towards the extreme right, you see are the measures of those metabolites. And we found that metabolites were lasting 3 days and 7 days. Oh, that's interesting. If the half-life of ketamine is gone in an hour and the response lasts 7 days, maybe it's one of these. We know that ketamine is associated with side effects, risk of addiction, and rapid antidepressant effects. So, through the collaboration, NCAT's National Center for Advanced Translational Research, the principal investigator is Todd Gould from University of Maryland, in our collaboration, what was done is one creates a deuterium form, a dideuterium form of ketamine. Means what you do is you attach something to one of its molecules or atom carbons, and what you do is you prevent its metabolism. And when you do that, this is what happens. Okay, you don't have the rapid antidepressant effects anymore, or very little, but you still have the side effects and the risk of addiction. Interesting, okay. So then you go to one of those metabolites that were hanging around, HNK, hydroxynorketamine. In animals, in mice, we found it had rapid antidepressant effects, but without the side effects of ketamine. Okay? So that's about it. I'm going to stop there, and thank you for your attention.
Our last speaker today, I'm pleased to introduce Dr. Raymond DiPaolo, who is chairman of the Department of Psychiatry and Behavioral Medicine at Johns Hopkins, and is the psychiatrist in chief there, and has been one of the world's experts on psychiatric genetics, especially in bipolar disorder. And he's going to share some of what has really become an extraordinarily exciting area of medicine. And as I mentioned earlier, I think the one that will yield us the biomarker that we lack.
Okay. How do you, where does that
I didn't use that.
Oh, you didn't use that one?
Yeah.
Okay. Well, we'll figure it out.
Okay.
All right. Well, thanks very much, everybody. It's nice to be here. I haven't regularly come to the Library of Congress since 1966, when I spent my summer in D.C. on Capitol Hill, and I loved it because it was the most peaceful place around, and you didn't have to do anything particularly special like you do these days. Didn't have to go through any. Didn't have to take. I didn't have an iPhone, but you wouldn't have had to take it off then. Okay. Well, listen, I'm a clinician first, okay, a teacher second, and a researcher third, okay? I've had a lot of fun doing research, and I have a lot of opinions, okay? And I've loved the first two talks, but even more than the talks, I've really liked the questions, okay? Because that's really what our field is about, okay, is getting the right question, okay? So let me see if I can start this little talk, and by giving me the issue of the genetics of depression, you know, I thought that sort of ruled out proclaiming victory on the genetics of bipolar disorder, okay? Which is not exactly victory, but it's certainly a heck of a much bigger start than we have on so-called unipolar depression. That is, people that have depressions but not bipolar disorder. So I'm going to talk, and I'm going to show you some genetic studies, but I'm going to show you the genetic studies really of kind of in stair-step fashion of schizophrenia, just to show the rapid progress that's been made there for whatever it is, okay? Then a little bit on bipolar disorder, and then, oh my God, depression, why haven't we done more there, okay? And then I'm going to talk about why is that, and also where's the problem. And I think, as I say, the genetic understanding of depression, there are two operative words there, genetics and depression, okay? So what is the right genetic question, and what is depression, which you all have already asked, okay? So let's go at it, okay? So I do have no financial conflicts with this, although whenever my faculty get up and do this, they always say I'm employed by Johns Hopkins. They make me do all kinds of things. And I'm saying that you will understand what we know about the genetics of major depression, that is the big challenges, and that you will see how the genetics of depression may be harder than for bipolar and schizophrenia, and that you will understand the need for large, stable collaborations, more careers studying serious mental disorders like depression, and better ideas. The technology is getting better every day, okay? And I've been blessed to be able to work with the people, starting since 1985, with the people that made the first map of the genome, and I got to work with them starting about 2 years before they made it, and by the way, the progress has just catapulted since then. And so I made Eric Lander, who was 29 at the time, and didn't really have an appointment. He was an unofficial fellow at the Whitehead Institute. He now runs the Broad Institute, okay, which is a very large genetic operation. I was just there about 2 weeks ago, and it's progressed just like the field has progressed, what you would expect. It's really cool. All right. So one of the reasons I like to do science is I get to meet really smart people and listen to the talks. And Carlos's work, you know, today he showed me some things I hadn't seen before, which is really great. That is that the the parent compound may not be the ticket. Well, that's important news. Now let's see here. I can see it right here. If I can, now I just put on my glasses and I can read it. Well, this is disease burdened by illness. I'm not going to spend much time here. Carlos and Phil and I have all referred to this, the global burden of disease studies, okay, in one way or another, to make the point that depression is big, okay? And so you can see that that's the number one on this particular thing. That was 2004. I noticed Carlos had it a little differently. He was looking at 2010. The main thing is, by the way, this was the biggest surprise in these global burden of disease studies. They were actually had to be persuaded to include psychiatric conditions, okay? And actually the person that persuaded him was the brother of one of my faculty members, Kay Jamison's brother, Dean, a health economist, persuaded them they needed to do it. And now they say, oh my God, why didn't we do it before? Okay, these are big, okay? And, okay. So what is major depression, okay? And so let me go right at that. And then the second question really is that's what it is? What DSM-5 says, okay? Is that really it? A checklist of 9 things? By the way, I was on the DSM-5. Carlos was a consultant. You were on it too. You were a member too. You and I are both members, right? And we both have gotten witness protection. So don't try anything funny. But it is great that we've had the challenge to this approach, okay? And it's not that these things are wrong. If you were going to come up with a checklist, way back when these things started, George Winokur from Iowa, now the late George Winokur, and I said, I didn't really like this way of doing it in DSM-3, and it's very similar. And he said, okay, just come up with something better. Just come up with a better checklist. I want a checklist, so just give me a better one. And I tried 4 or 5, and I said, okay, George, one works about as well as the other. But these things came, these things came from some bright people at WashU in St. Louis, and where they came from was the walls inside where the clinical research groups were, okay? And so what the young fellow named Feiner, and the Feiner criteria became the DSM criteria, sort of, you know, by little switches and committees that morphed them one way or another. He went around to the anxiety group and the depression group and said, who gets into your study? Okay, here, son, go mimeograph this. Okay, that's how they get in. That's our checklist. Okay, and that's what this is. When he initially published it, it was for research. Okay, and I think that's what they serve in, not in the sense of guiding the research at all, just in saying, well, you got to have some minimal qualification. Okay, so now, okay, so anyway, so this will do pretty well. Okay, especially when it's recurrent, especially when it's early onset. You've heard about that, and then especially if it has the other manifestations that Carlos talked about, psychotic symptoms, severe suicidal symptoms, etc. But at any rate, as this has gone on, the controversy about this approach to diagnosis, which has been very much deserved, okay, some have said we even invented it, and I just want to make one slide to say we didn't invent it. Okay, this is Burton's Anatomy of Melancholia, 1621, but you've already heard about Hippocrates and Galen. They knew about this too, okay? So that question's answered, okay? By the way, I do want to come up with an answer about why we haven't evolved out of it, and I'll tell you that later, okay? Okay, so melancholia, okay, and as you know, this comes from the ancient disease model, which had to do with the four humors, okay? And in this room, people know what that is. When I go to medical students and I ask who knows, the derivation of the word melancholia, and essentially it's 0 to 2 people in a room of 50 will know, okay? So too much black bile was thought to be the source, but Kraepelin really didn't buy that. And Kraepelin was an early applier of the modern disease model to psychiatry, okay? And he was a pretty fair pathologist. He had a better one as one of his students, Lois Alzheimer, okay? And the guy who started our department, Adolf Meyer, was a very good pathologist, and he didn't like Kraepelin doing this because for what he called dementia praecox and manic depressive insanity, he says, because you don't have a pathology yet. And that's the centerpiece of the modern disease model. And he said, if you do that, if you allow these things to be called diseases without a pathology, there is no limit to the number of things you might call diseases, right? And Dr. McHugh used to hold up DSM-4 in its thick form and say, this book should be called Myers' Revenge, okay? Any rate, but here's a patient, and I can't get away from it. This is also from Kraepelin's text, and he showed the woman who had in 2 pictures. I'm showing the man who had 2 pictures. It took a little work. You had to go through it a couple times because these pictures were like 50 pages apart, and they didn't tell you, hey, this is the same person that was on page 20, okay? So, but here's the fella in melancholia. He had been said to be like this, wide-eyed stare, having to be persuaded to pull the covers down a little bit so they could take a photograph of him, okay? He had no interest in anything, and you can see he's unshaven. He looks a lot better than he probably felt at this moment, okay? So that's melancholia, and that's the picture of melancholia, all right? Now here's another patient that has melancholia, and I'm going to talk to you a little bit about these 2 patients. I'm not going to talk about Bob. I'm going to talk about these 2 people. So here is a woman, and by the way, without a checklist, what would we say are the central features of the syndrome of depression, if you will? And we would say it's a change in mood or affect, a change in self-attitude, and a change in vitality, okay? And they express themselves slightly differently. Actually, only about 50% of people that I would diagnose with depression would say that that's a good description of what they're feeling. They also often say they're not so much sad as they are anxious, apathetic, don't care, or even numb. And people have told me, I can't even cry. Couldn't cry at my father's funeral, okay? There's something wrong with me. I can't feel anything, okay? The change in self-attitude, which is so characteristic of what we call melancholia, okay? It comes in degrees. You can have just decreased self-confidence. I don't trust any of my decisions now, tells the businessman to me, even though he's still going to work. But in the worst case, a lady like this often feels hopeless and worthless, okay? And then vitality, some people use the word vital sense, but I like just the word vitality, and that is lacking normal physical and mental energy, okay? And the issue, we talk about poor concentration, but that really is that it takes energy. That's one of the reasons many people don't want to see other people. I got to get up. I've got to look half decent, and actually I've gotten a number of patients to appear on be filmed in one thing or another. And when the people come and say, hey, look, we want to film a patient before and after, and I say, well, okay, good luck. Most patients tell me when I go in and they're feeling like this lady's feeling, Dr. DiPaolo, I'm not sure I really want my family to see me making a debut while I'm feeling like this. Could we go a few more days till I'm feeling a little bit better, okay? And because this is a time in which you don't feel like doing much of anything. And in fact, here's what she's saying. I'm falling down in my head. This is in Paris, so this is a translation. I'm falling down in my head. I no longer wish to live, to see anything, hear anything, feel anything. I'm fed up with life. I've had enough. I don't want to live anymore. I mean, now there isn't a better description of depression that we've got. But of course, it's a cross-sectional thing, and so let me talk to you about her. This is a lady who had Parkinson's disease. She had never had depression before, okay? And when they put in the electrodes and let that surgery heal, they were going to try to help her tremor in Parkinson's disease with this deep brain stimulation electrode, okay? And the first time that they had her on, because this was an early case, they videotaped her when they turned it on. They were, hey, this is going to be good, right? And it didn't come out the way they anticipated, okay? And so you can see here in A, and I don't think I have a pointer here. Do I? Oh, do I really? No, I just screwed that up, didn't I? Okay. And in section A there she is as she came in to get ready for the thing. And then in B is after 17 seconds after they turned on the stimulator, 4 minutes and 16 seconds is when she's telling us that this life is worthless, okay, that there's no point in going on. And then, of course, being very smart, and one of the great things about surgeons and people that use treatments like this is somebody said, turn that blessed thing off. You know, bang, hit the thing. And very quickly she recovered, okay? And said something like, did somebody get the license plate, you know, on that truck that just ran over me? And in fact, as she recovered, she actually had a little over-recovery and started playing with her surgeon's tie, okay? But that went away very fast, just a momentary. So this is one of the reasons why we think the modern disease paradigm is appropriate for this. But these paradigms, by these models, you know, you got to remember what the great statistician Box said. George E.P. Box said to his students, all models are wrong, but some are useful. Okay, so it's a construct. That's all it is. Okay, only the patients are real, I tell my students. All right, so now that's one patient. Now here's the other patient from his depression to show him now in an altered state, you know, a year or so or several months later. And you may not be able to make it out, but you can see the cigar he's smoking. And if you're good, you can kind of see the pipe and on his lap, that's actually another pipe. Okay, so this guy's really indulging at least one particular appetite. Okay, and seems to, and he, by the way, he's also wearing a boutonniere, if you'll take notice, and he no longer has that big beard, but he does have a nice handlebar mustache. Okay, so and this, you know, Kraepelin said, I don't have any particular treatments for this disorder. These were people who were living there, and they were just mostly observing them. Okay. So, and just to make the point, the central features of mania are similar, almost a mirror image of depression, not completely. And so the mood is mostly elated, but not just elated, irritable, expansive. Self-attitude is up, grandiose, overconfident, and imperious often. And vitality is increased, energy, and a perception of a decreased need for sleep. And in fact, patients can go, you know, as you know, 3 or 4 days without sleep. And then increased speed of thinking and speech, usually. And again, with both of them, there tends to be an episodic course. And in fact, in Kraepelin's day, he grouped people together who had only depressions and manias and depressions together because he thought, look, that's the best predictor I have. And so that's actually one of the ways we had to divide depressions, okay? Those that have mania and those that don't, okay? And it's still salient, okay? Well, here's the modern disease model, if you will. This is not a definition of the word, because you can't get anybody to agree on the definition of the word, but this is the structural model. We doctors like simple things that you can operationalize, okay? And so here's the model. You have the clinical syndrome. You validate that as a modern disease with a pathology, an abnormal body part, okay, in some fashion. And then that leads you to search, if you do things in that order, in the right order in a sense, for an original cause or etiology, okay? Now, the problem for us is that none of these areas are simple. In cancer, etiology is very complex, and we learn a lot from them in studying etiology because they know the methods, they know how to go at that, okay? It's really good. But once you get a cancer, by the way, the pathology is not complicated. It's just stuff growing where it shouldn't be, okay? It doesn't look very good, kind of ugly stuff growing where it shouldn't be, okay? And the syndromes are also not complex. It blocks something or it causes pain, right? Or it causes a protrusion, okay? So, and the reason I'm mentioning this is I was invited to speak at the Salk Institute annual symposium on biological complexity. And I saw that much of their earlier ones were on cancer. And I said, well, Jiminy Christmas, if you're going to make me talk, I've got to say, you know, my talk was entitled Complexity Squared. I should have said cubed, okay? Because each of these is a complex state, okay? And it is not, in all likelihood, going to be explainable solely by its parts, okay? And that's really a key thing. Now, that's what makes it so wonderful and amazing to study the patients and to work with them. But this is complicated, folks, and therefore we're working on systems within systems, okay? So now, I said the course was episodic. This is an early slide, one of the slides that where they used lithium in patients. By the way, it's unipolar and bipolar in here. The black bars are the depressions. The hatched bars are mostly the manias. And you can see the lithium is where the little pencil underlinings are, okay? And each line is a patient, okay, from 1960 to 1968, okay? And it looks pretty good, doesn't it? That looks terrific. You're going, man, you should keep yourself with that pencil line going underneath you. And it didn't turn out to be that good, but it did turn out to be good, okay? And this was 1969, and my teacher from the Maudsley Hospital, the Institute of Psychiatry in London, though, didn't like this study, and so he wrote a paper with his fellow called Prophylactic Lithium, Another Therapeutic Myth, okay? That generated both heat and eventually light, because they got some really good studies done, but everybody was really mad for a while, and so forth. Now, why did I end up going there? Okay, I'm not sure. I'm going to come back to this in a minute. Okay, right, okay. So here we're going to talk about, I'll come back to this in a minute, that in general, genetics of psychiatric disorders, that is at least the ones, schizophrenia, bipolar, and depression, have been difficult. And I started in the area, got our first grant in 1988, and through about 2005, it was, what we got was experience. And of course, experience is the name you give to your mistakes, right? And I did discover, had 3 great discoveries, and those are 3 young people that were much smarter than me, and they're now actually running great programs around the country. But eventually, when we started coalescing samples into very large samples and had access to every sequence variant in the genome, and easily could do 1 million variants at one time, and now can actually sequence the whole genome as well, things started coming out. Okay, and this is just to show you, this is the 12 or so for bipolar disorder, although you'll notice down at the bottom that it says BD plus schizophrenia, okay? So that there are both overlapping ones with schizophrenia and ones that don't appear to be overlapping. Down at the very bottom, you see bipolar disorder and RUD, that is recurrent unipolar depression, okay? And so, that's, it's very interesting, but the one that's been toughest to do is depression in any of its forms. Bipolar depression better than non-bipolar depression, but why? It's so much more common. It's about 8 times more common than bipolar disorder. And I'll show you some of the samples that have been ascertained. But I'm gonna I'm thinking if the slides are in the order I'm hoping they're in, yes, I'll be telling you a little bit about how the progress has gone when you have funding, sufficient funding, and sufficient samples, okay? And basically, the sampling methods, when Dr. Insel stopped wanting to pay for phenotypes, the investigators are resourceful people, and they went and purchased everybody in Sweden, right? All their DNAs from Sweden or from Denmark, and that's really good. Those people have health systems. That absolutely was the right thing to do, and they had a reasonably robust way of making diagnoses. And so by 2011, once they started doing that, they could do 1 million markers, okay? Each one against, and this is, you can see here, it's chromosome 1 on the left, if you can see it, and the chromosomes are 1 through 22, leaving out the X and Y chromosome, and so that these are, if you could think of them as tipped over on their side, and then up at the top, going up above this line where you see between 7 and 8, is the point at which things become statistically significant. But this requires like 10,000 samples to do it. And that's not easy to come by, okay? And so the group, particularly at the Broad Institute, and with collaboration from the clinicians and toilers in the field who actually see the patients, came up with this in 2011. And then they just got a few more samples, doubled the sample size, tripled the sample size, and by 2013, they actually, and the red line is at the same place, by the way, folks. It's just the scale here has changed. The top of the other scale is 12, the top of the scale is 30. And that's the exponent of the p-value, okay? For those of you who live in that world. But the point is, they now have here 108 loci, presumably, for the most part, genes, okay? Sometimes they can't tell if a loci is of this particular gene or that one or of both. And you can see, by the way, the tallest one there is that in schizophrenia forever has been on chromosome 6, right in the major histocompatibility region, which has been, in one sense, the Bermuda Triangle for geneticists trying to dissect it because it's so complicated, okay? But that has now been dissected quite well in schizophrenia, and we now have a component of the complement system, C4, that appears to be quite abnormal in schizophrenia, okay? Not necessarily in all schizophrenics, but with a sample size like this, they could dissect it down. And so it looks like it's going to be an important clue. And by the way, did I ever expect that we would find the cause of all forms of these? No, I didn't. Keep in mind, these are syndromes, going back to that model. And whether it's congestive heart failure, if we did a genetic study of congestive heart failure, that would be too complicated. Well, these are syndromes, and we don't know really if there's a level of congestive heart failure for us, which might be simple, versus dropsy, okay? So that we don't know where we are because we haven't yet we don't have a pathology, okay? Really the simplest way of looking at it. Now, these studies have been very important, and I'm going to go backwards here to pick up this slide. And that people noticed that so many of the genes that were being identified had multiple diseases they were associated with, okay? And so this early on led some people to say, well, Kraepelin was wrong. It isn't manic depressive insanity and schizophrenia. It's all really one thing, okay? They are now, I think, not saying that anymore. And you do want to wait and see how things turn out. But there's no doubt about it that there are a lot of shared genes in this thing, okay? And I'm going to get to the question a little bit about why have we not evolved out of depression, okay? And so that what you can see is ADHD, BPD or bipolar disorder, schizophrenia, major depression, and autism spectrum disorder. And that's just the heritabilities for each, okay? And then what they've done then is looked at the co-heritabilities between disorders. And you can kind of see that. And what you can see is that bipolar disorder and MDD are related, it seems, but no more so than schizophrenia and unipolar disorder are, okay? And schizophrenia and bipolar disorder do seem related, at least in some significant way, okay? So that shouldn't be too surprising. I mean, the genetic overlap between asthma and Crohn's disease is substantial. But they are importantly different diseases, but they also are importantly the same in some ways, at some molecular level. Okay, so I've done that. So look, that's the kind of, if you will, the sort of the story of genetics. Now, the real issue is what we want, though, is if we can't find everybody's model of their disease, what we'd like to do is at least find one, okay, and say, can I figure out how Mother Nature made one case of bipolar disorder? In fact, that was my goal when I started these things. Just need to find one, because that'll at least give us something to look for other things to come in. And it's like in Alzheimer's disease, the APP mutation, the amyloid precursor protein, was tremendous in that way, even though it accounts for less than 1% of the disease. But it gave them a model. And the model, by the way, now has put the amyloid hypothesis a little bit on the back burner. Whoa, I did something bad. What'd I do? Hit. Okay. Oh, good. Thanks. Thank you. I feel much better. My stress level just went down. Oh, everything. I stopped degenerating there for a minute. Okay. Sorry, where the heck was I? At any rate, I want to find out how Mother Nature made one case. Okay, and that has helped other diseases. Okay. Okay. This is the one. Oh, by the way, this is the study I was going to show, last study on this, to show you when they put 5 disorders together, okay, and pretended that they all had the same thing, the 5 that you've already seen, they could still find things that were significant. I think this is, to be honest with you, kind of child's play, okay? I don't think it's terribly helpful because we know ADHD is different than bipolar disorder, and the fact that they have some overlap, terrific, good. That should tell us something important, but this is not, to me, too surprising or too informative, but it is what it is. So now here's the point is that people have now gotten on to major depression and they've collected large samples, and the thing is we don't have much to show for it, and we should by now. In fact, with these disorders that are so heterogeneous and complex, you can actually calculate, and since we assume they are all basically polygenic because we haven't found any autosomal dominant or autosomal negative or X-linked forms of it that are simple, okay? You would think by the number of people we've collected with major depression now, we should have 20 or 30 loci linked to it, okay? And we don't. And so, well, you can say that's terrible, you can feel discouraged, but you can also say, all right, time for an idea, right? Time for somebody to look at this in a different way, okay? And we'll just talk about that, because there are some simple ways to do it, but there are some more interesting ways as well. They might be a new treatment that gives you insight or a lot of other things, okay? So they, at the group, the Major Depressive Disorder Working Group, again, a large collaboration, had 18,759 independent, unrelated subjects of European ancestry. 9,000 in some had major depression, and 9,500 were controls. And then they had a replication phase, because in these days with this big machinery, you don't want to publish a finding unless you can also replicate it. They had a second sample waiting, where they had 6,700 cases and 50,000 controls, okay? And no gene or locus achieved genome-wide significance, okay? Now, again, that doesn't mean there aren't any. It just means that with all this multiple testing, testing 1 million markers at one time is going to cause statistical issues for you, because you'll have, if you lower your threshold, you'll have more false positives than true positives. Now, we don't want that, obviously. Now, so it was interesting. And then actually, even in their secondary looks at major depression, they took ones where males and females, because there's a big difference there, recurrent versus non-recurrent, recurrent and early onset, and just age of onset by itself, and none of them came up either. Now, each of those, by the way, would shrink the sample size, okay? But that's where we are. And in the MDD bipolar cross disorder analysis, which is one of the things that we think is going to be important, there were 15 SNPs that did, but they were all at one place on the chromosome 3, okay? That did exceed the genome-wide significance. But in bipolar disorders, I was saying, we now have about 12. Some people would say maybe it's going to be up to 30 in a few months. But the issue for schizophrenia and for us is, for the most part, we still can't turn those genes into a story, into a model. Okay, and that's why we need insights, non-genetic insights, as well as digging away at the genes and looking at what they actually do. Okay, and the technology even for doing that is amazing these days. And like the CRISPR technology actually allows you to keep modifying a variant and seeing what it does in cell cultures. You know, how it acts differently. And so that's really cool. It blows my mind. Okay, so now here's a point I want to mention. Okay. And actually, on the one hand, a replication, it's true, Carlos, is hard in psychiatry, but there are 1,000 slides that look like this, okay, as you know. And this is some antidepressant and a placebo. This one is actually lucky. They were very lucky. They got an effect in 28 days. As Carlos says, it usually takes longer than that. But basically, what this is showing is two things to keep in mind that do make this not so easy. One is, the first week, placebo is working darn well, isn't it? Okay, that's number one. And with restoration of hope, you know, I know what's wrong with you. I'm going to treat you. You're going to get better. But as I tell my young psychiatrists, after a week, you better have something in the pill. Okay, and then after the 1 week is over, they separate. But this doesn't really show you the scatter. Okay, and what you'll see with the tricyclics is that some people get just flat out well. Okay, and some people might go get even worse than this. Okay, having said that, but as you saw from the STAR-D study, that only about 30% of patients will go into remission in some reasonable time period. Okay, and the others will get, at least 50% improvement. By the way, 50% improvement if you have a bad depression. Do not brag about that one. Okay, because people still, don't want to get up the next day on 50% improvement with these kinds of patients who, by the way, these people are starting with a Hamilton score of 30. That's big, and that's a patient admitted to my inpatient unit. Okay, now everybody says, but wait a second, we're treating so many people with antidepressants now, okay? And we gotta, why aren't we reducing suicide rates, and why aren't we, reducing the prevalence, or at least the point prevalence of depression? And here's part of the answer, and this comes from a young man he did this work when he was at Columbia, Ramin Mojtabai, who's a joint recruit. He's in the Department of Mental Health. Hopkins has the only Department of Mental Health in any school of public health in the world, as far as we can tell. If somebody knows differently, I'll be happy to hear it. But I think that's tremendous. And they have a group of people, they are our kindred spirits and our secret weapon, okay? So Ramin went out and looked at this, and what he saw was that most of the increase, okay, in the use of antidepressants is in patients where the doctor isn't even giving a psychiatric diagnosis in the chart. Now, many of those people probably have anxiety disorders. These things, the SSRIs work quite well for anxiety, okay? Some of them, who knows what they're getting it for, okay? So, and the interesting thing is, if you study severe forms of major depression, there's not an appreciable difference in the percentage of them being treated actively with a treatment that would beat a sugar pill, okay? So the antidepressants are multiplying, their use is multiplying. 80%, of course, are prescribed by non-psychiatrists, but the psychiatrists aren't perfect. I don't want to put us up as the gold standard, but it is true that in the primary care clinic, thank God they are now talking about putting us with them in the primary care clinics and trying to help them, because they know this is a big problem for them, okay? So now how else might we get there? Carlos showed you one way. If we can track back through the NMDA receptor, and he showed us both that receptor and the AMPA receptor, each of those look like great targets, okay? Would that be useful? Here's one that we heard the other day in bipolar disorder from one of the members. By the way, I'm going to stop being chairman of the department at Hopkins in June after 14 years. It seems like 17, but it's only been 14. But I am already the chairman of the board of the National Network of Depression Centers, and I do want to mention that because we're going to need that. Okay, I think. Okay, I think it's so. But here, if you can see it, if you can make it out, the red and the purple, and then the light green and the darker green. Are cell lines, okay, that are turned, these are deprogrammed cells that are then programmed to be like neurons, okay? And what you can see in the top bar, the red and the light green, these are in their native state without lithium on board in the cell culture, okay? And they are firing in a hyperactive way, actually. I don't know that you can tell that, but this is hyperactive firing, okay? But these people where the cell lines were made from were already treated for a number of years for their bipolar disorder. And some of them were selected to be excellent lithium responders, the kind of people that just seemed to get well on it, okay? And others were not so good lithium responders, okay? And in the ones that were the lithium responders, that's LR up here, okay? And in LR, look what happened in the purple compared to the red, okay? So only in them, though. You go down below, light green to dark green, really not much happened at all. Okay, so it does seem that there may be something about this, you know, and if it were hyperexcitable neurons, that would be great, because then we'd think about mania and have a visual image of it. But, you know, at any rate, it is useful. And this was done out at UC San Diego with John Kelso as the lead psychiatrist and Fred Gage as the stem cell guy, if you will. Okay, so by the way, at the end of the day, they're comparing a very small number of people's cells here. Okay. So we need to replicate this, and if confirmed, we need a way to test it in larger populations to see if we can turn it into something that's robust, just like we're trying to do with the ketamine response. We know there are people that respond to it. How can we turn it into something that's robust, okay? So, at any rate, look, on the one hand, we still want the genes. Why? Because even though we have a lot of stories that make partial sense of these conditions, we still need to have a parts list, and that's Eric Lander would use that term. I want the parts list. And then let's see how it'll still take a while to construct them, put them together in some forms that look rational. And to do that, we're going to need 30,000 cases or more, okay? And looking at particular treatments, as Carlos is doing, and their molecular targets, and associate them with genetic and other molecular variations, certainly a good idea. But if the genetics and the neuroscience doesn't tell us what depression is, okay, ours is a working hypothesis, okay? If they don't tell us, then we're going to have to try and redefine it ourselves to see if then they can do it, right? Okay, so that is really the question. What is depression, as much as how do you do the genetics of this thing? So Phil mentioned prominently melancholia, and I think that is an important point, and because many of the older professors, like Phil, who are very smart, have said, wait a second, with that checklist, you're including way too many people in this thing, okay? And is that the problem, okay? Now, one problem with undoing that is that we know from past studies that people that wouldn't qualify for melancholia, they didn't look like they had melancholia, they looked like they had pretty garden variety, mild or moderate depressions. Some of them respond quite well to antidepressants too, and I don't want to deprive them of treatment. The problem is they look identical to their brethren out there in that part of the Venn diagram, okay? And some of them are responders, some of them are not. And so probably what we've got is an admixture of some sort out there, okay? So that's that. So where do you draw the circle? Now, by the way, the folks who don't go back and read the old literature, they say, but Ray, if you do that, it's going to take you another 20 years just to get a sample, because you're going to lose power if you don't have a big sample size. Well, okay, next question. Okay, right. So how else might we divide it? So melancholia versus the major depression that's not melancholia would be one sensible way if we could get enough samples. Major depression associated with stroke, there's a very regular relationship on depression that follows stroke and brain lesions. But there's probably a genetics, just like there's a genetics of at least resistance to HIV infection, right? Major depression associated with bipolar disorder, we've already mentioned, but also major depression associated with Parkinson's, although that lady had deep brain stimulation. 50% of patients with Parkinson's get depression, and they get it early, before their motor symptoms are dramatic. And by the way, similarly, Huntington's disease patients do, and some of them get bipolar disorder, and it usually comes early in their illness. By the way, that part of the brain is now a very hot topic for us as well. It has been for about 30 years, but 40 years ago, we certainly didn't. When 1966, no one was thinking that the basal ganglia were going to give anything to psychiatry, but they're key. So, and then again, say my favorite category is major depressive disorder associated with who knows what. Okay, right. So, so now look, but I was told by Phil that this thing was called depression. Can it be cured? It says right here on the top of the page, and I thought, now that really is a vexed question, Phil. And look, on the one hand, we need better treatments for sure. There's just no doubt about that. Okay, so that, go ahead, keep seeking that. But my oncology friends, they rarely use the word cure anymore. They say, actually, some of the more dour ones tell me that a cure is when you die of something else, you know, when you're not depressed. Okay, and so in that, by that account, I've cured a couple people. Okay. So whether the cure or long-standing remission, I'll take long-standing remission too, although, by the way, we can cure it. Why wouldn't we? But it may be that we'll have to see. And it may be that that's not a realistic way to look at this disease if Phil is right. Because if it is, why have we not evolved out of it? Well, it's got to impair your reproduction, number one, okay? And two, it cannot involve things that are vital for your function, for the body to work, okay? So, and with 100 genes likely, maybe 1,000 genes, it's part of this. Hey, guess what? These things are probably important, as Phil said. So, sorry, we didn't turn out perfect, but, and this may be, as he says, the price we pay. Having said that, if we can get good at knowing it when we see it, we can do what he's suggesting, and that is working with the patient, okay, in all manner of ways, okay, to help them manage this, okay? And that's what I do, and I love doing it. And they used to talk about that. One of the things I didn't like when many of our colleagues were out there doing drug studies and saying, treat to remission, treat to remission. I'd say, great, just tell me how. I'll do it, I do it sometimes, but it doesn't happen all that often. And what I like better, the recovery concept, because that means recover your life, okay? So if I can get the person functioning again, I say, be careful, everything I do is empirical. So the next thing we do, let's take a little time. You're actually functioning a little bit now. Let's use that for a little bit, and then let's come back and think about treatment again later. So I do think that this may be part of the nature of our machine and our mechanism. It may not be curable on the one hand. On the other hand, this work, as you can see, I think, and with these two people in front of you, is for the committed, but also for the well-supported, and not just financially, but that too, okay? And it's not a quick way to fame and fortune, as they can attest. Answers may come in small steps, though, also, like cancer. So now I'm going to switch to that other talk, just to show a couple things, okay? And we'll, okay, thanks. And this is my National Network of Depression talk, and I'm just going to say, look, we do need these large multi-center networks that are stable, that aren't changing every 5 years as funding changes, okay? I believe, but now it's going to take a while, because we need very large samples with the power to find genetic and brain imaging changes that will illuminate causal pathways. We need to go beyond expert opinions in setting up our so-called guidelines. Evidence-based medicine is really expert-based medicine in our field, and we need to have a way of, our plan is to have about 20,000 people under care using the same essential record or instruments, and to share the data, so that although that's observational and therefore hypothesis generating, it can be a little bit hypothesis testing in the practical world to say, hey, you think it's that way, let's go look. Let's take a quick look and see how the people look. So there's a lot of reasons why we need this. And so we do have a network of National Network of Depression Centers, and there is forming, I think, a network of networks. So there's a Canadian group of 6 centers, and there's a group in Germany that looks like they will come in as well. And we have 25 centers working to collect patients in this manner. And I just thought I'd mention that because that's going to keep me busy for a while. So why don't I stop there and answer questions. Thanks very much. And I'm told we have a relatively short time, and the other two guys should come up here and join in the questions. Are there questions? Yes, sir.
Well, that's a terrific talk. I have a lot of questions. First of all, are there cultural variations in depression? The reason I ask that is I'm a visiting professor all over the world, and in my unscientific observation, there are huge cultural variations. The Norwegians are the most damn depressed people in the world. And the Italians, I've been a visiting professor all over Italy. The southern Italians are the least depressed. And I wonder if this
I wish
is
that were true.
unscientific.
My name is DePaulo. I wish that were true.
Yeah,
okay.
Is there any scientific basis for cultural variation?
A little bit. There is a milder form of depression, or even what used to be called bipolar 2, where there is a distinct seasonal variation, and which you will see maybe some seasonal variation, okay? But by and large, these things, even Kraepelin, way back in the 1890s, took a trip to Java at one point so he could find out how it looked in Java, and he said, hey, it's basically the same. So the rates vary, but it may be that translating that checklist into 12 languages doesn't get you there. So we don't have, the evidence is not robust, let's put it that way, okay?
Okay, now can I ask another?
Good. Yeah, sure.
Yeah, that checklist I think is very suspicious. The checklist is doubtful because those are good checklist for old age.
Yeah, right.
Do you have less energy? Do you think more about death? I mean, what that proves is you're old.
Tell me about it. That's
and
right.
I'd like
That's
to know
right.
more about that.
Yeah.
Okay, but I don't know how many questions I'm going to ask, but I'd like to ask one thing about the medicines. The second speaker told us that ketamines were just great, only they're addictive.
Yeah.
Well, thanks a lot. I mean, I can cure a lot of symptoms with cocaine, but you've got a side effect that's very unfortunate.
Yeah,
And
well, look,
now,
I mean, that's right.
The other part of that question is, whatever happened to lithium? When I was a kid, an undergraduate, everybody had depression and they all got cured by lithium. Whatever happened to that?
Well, it's interesting because as an acute treatment for depression, it doesn't seem to be as good as we thought back then. Okay, but it does seem to have prophylactic value in severe unipolar patients and in bipolar patients, but not for all, as we could show even in some of our studies where we're looking at mechanism. So it's daggone good, and now that we've learned to use it better, we have fewer renal side effects in the long haul. It's a drug that's underutilized in this country. While there's still a treatment of choice in Europe for bipolar disorder.
I could
go ahead.
address the second part about ketamine.
ketamine.
So again, I think I conveyed that we study people who are very ill, and in fact, they have failed all the treatments for bipolar disorder, for depression and ECT, and most were having suicide attempts.
Yeah, you'd take anything if you were in that state.
But you do bring up a point, and so it's an issue of progress. We thought back then it was ethical to study a decade ago, and it does work. And so as researchers, we don't give up. We just try to find something better. And I think the recent study suggests we can find something better that's not addictive. Hopefully, more studies.
Well, this is in other words, this is of great heuristic value. It's got us looking at a different part of the mechanism.
The issue would be, for example, the Wright brothers. Who would have gotten up in a plane? Nobody today would probably go in that, but yet we travel all the time because of progress that has been made.
So did they have to put that through an IRB?
They had to put that through an IRB.
That's right. Yes, ma'am. And we go right there. Go ahead. Yeah.
Thank you. I have a question for both of you, particularly for Dr. Zarate, about how open these data are. I mean, given the amount of investment over long periods of time, this is a very obvious case for open data. So can you tell us a bit more about where these get deposited, how standard the protocols are, how readily reusable they are, and how
You want me to take it or you want to take
how
it?
much reuse they've actually gotten?
Well, look, this is an idea that goes way back, and it's a very good idea, okay? And when I, again, worked with David Botstein, he said that's what he wanted. He wanted our data to be out there on the web. Actually, the woman, Mary Claire King, who deserves so much credit for the breast cancer genes, that's exactly what she did, and that's why she didn't clone the gene, because she had a company working alongside her, looking at her data on a daily basis, every 24 hours, and they cloned the genes and then misused the patent, which was later revoked. But that's what we should be doing, okay? In this era of quote-unquote team science, it's not just team science, it's crowd science, okay? We got to quit. We got to help people make progress, okay? And so I think there is still some protectiveness, but there's another point. Not all data sets are equally readable, okay? And there is a lot of, unless you really are good at setting up your data set, your database, you can get it back and it doesn't look like much. Now, So talk to me about what you have access to.
No,
Those
there,
things.
at NIH, there are concerted efforts that, if
Right.
you won't get funded
Yeah.
unless you put your data in a public repository. And there's some rules about 1 year or 2 years protection for the main thing. But that being said, the IT and the infrastructure is one database doesn't talk to the other database. The quality of data obtained at many sites is probably not as best as we would like, but there are those efforts. Then it's not only that, it's the computing power. Once you have these humongous sites, how do you analyze it? And so computation is really a big
It should be done, and now they're requiring people to do it, but that doesn't mean it's being done in a way that's terribly illuminating, okay? I always think back to Art Buchwald, from the late Art Buchwald from Washington, and when they were talking about how to do the MX missiles, for those of you old enough to remember that, he favored the idea that we would put them on rails and run them around the country, and he said we should give the Russians a schedule. They'll never figure it out, okay? That's the way you feel when you look at some of these databases, okay? I want you to say that when I did start this research in 1988, I started in 86, but we didn't get funded till 88. What I said is, what can we guarantee? We can only guarantee that we do really high-quality assessments of the patients, that we create an excellent clinical database, and that we make good DNA, okay? I want you to know we did all three, and what I say is what I discovered were 3 young people that were really terrific, okay? Yes, ma'am. Right behind you. There's a lady right behind you, actually, who had her hand up. Right.
Have there been studies that look at people who have a severe depression, they use a treatment, they get much better? Has anybody followed some of these people to see, like, if they stop their medication, do they continue better, or do they get worse and then have to have another treatment, the same treatment?
Good question, Carlos. So you can start there. The answer is yes. And basically, what we can tell you is, for the most part, that what gets you well will keep you well. And if you go off of it, you're on nothing for the most part. In recurrent depression, that's the thing they mostly found. Having said that, no, absolutely right. They're not cured. No, I agree with you. That's remission at best. No, I completely agree with you. Okay.
Yeah, we now prescribe medication. Think about, usually you give an antidepressant, and that's the acute phase, which could be 6 to 12 weeks. And then if you're responding, there's a continuation phase that goes 6 months or a little bit longer, and then there's a maintenance phase. And for the first episode of depression, some have argued you could do psychotherapy for CBT, or you could do an antidepressant, but after 9 months, 12 months, maybe a little bit longer, if you have one episode and you have family history, don't have significant family history, you may be able to consider coming off. But the problem with that is, if you have stronger family history and the more episodes of depression you have, if you've had one, there's a 25% chance of a second. If you had 2, there's it goes to 50, and for each subsequent, it goes up to 75, even higher. And so if you had somebody who's already had several bouts of depression plus family history, the likelihood is they will need treatment for a long time.
By the way, let me add one other thing there, and that is I thought you were going to ask me a tougher question. That one was kind of a softball. And that is, the one that really is frustrating is the patient that gets very well on a drug and continues the drug and relapses terribly. And that was at one point called the Prozac poop out. It's not about Prozac. It didn't change. Huh? It does, especially in certain kinds of patients. I think we'd probably, in the patients that have these chronic depressions where they have at least a little bit of depression almost all the time. Those patients tend to have that response. Other question? Got a couple here.
I do not have a scientific background, so let me see if I can phrase this question properly. Suppose you showed in your genome that you expressed enough of the genes that showed you had a genetic predisposition for depression, but you might not get depressed.
Yeah, absolutely.
But have you done studies on children specifically? And I don't know how you would do that when you're studying, your focus is on genes. I come from a background where I know I developed depression because of situations that affected me when I was a child. And I also think that there's a predisposition to depression in my family, and I have a brother and sister who have not been as affected as badly. And I'm the oldest child in the family, but I think that there is a tragic lack of attention to children, especially who are symptomatic and possibly in a variety of ways. And if anybody was paying any attention to them,
Yeah, well, we have a great department of child psychiatry, and we do pay attention. We do pay attention, but I do want to tell you that in terms of the genetic part of it, those studies are not yet really being done. I mean, because right now we don't have a sufficient set of genetic markers that we can say this person has a 50-50 chance of getting depression. Okay, we're not that powerful yet. Okay, having said that, people have taken any particular gene that seems to be related, and they studied in children who do not have depression. And it's very interesting what they find, because they often find some change, like in their cognition, their concentration, things like that. But those studies are things we absolutely want to do. Okay, and but we first got to come up with the parts list, I think.
Well, I mean, you kind of responded, but there is more and more, because of, as you can see, in unipolar depression and bipolar, the findings are not as robust as we would like, or for unipolar, very little, that now genetic studies, are moving that you need to consider the environment, the family, and all that as well. If you're not considering those two things, I mean, maybe it's more information that hopefully will give us more insights. And so most of the studies that I'm hearing, at least, the collaborators I work with are really going that way. How do you do that? And it's very hard.
If you take two identical twins who share 100% of their genes, and one of the identical twins develops depression, only 50% or so of the other identical twins will develop depression.
Yeah. So, and why is that? Good question. Don't know. Okay.
Well, I want to follow up on the cultural question that he posed earlier on in a different direction. And I'm posing this question from my own background, in which Pentecostalism, the Bible, is taken as an answer, and Pentecostalism is on the rise. I'm part of this is a belief system. It has no scientific. I'm not standing here to talk about its science. Part of what is able to capture is its capability to treat many of what you have discussed. And they do make that claim very powerfully that they are able to do so. I don't have any way of validating it.
Yeah.
But it gives rise to a question. Is there a way in which alternative non-medicals we are suggesting can be formulated? But because I also come from a culture where there's a lot of belief on witchcraft, on sorceries, and they approach them via methodologies that are different from yours. And we're beginning to say, let's stop questioning them. Let's now begin to understand them. And there's this famous Nigerian Lambo who became the head of the World Health Organization. He's dead now.
Okay, listen, that's a very good question.
Yeah.
I don't know if these fellows take a shot at it. So how about religious cures, if you will? How would you look at them for the people that say, gee, in our church or in our way of believing, we can take care of this? What do you think?
One of the most important aspects of the psychotherapy is the development of a therapeutic alliance. There is something that is helpful and that can be useful when one person meets with another and they develop a meaningful relationship and they begin to trust one another. There are placebo effects also, but I think that there are many different forms of psychotherapy that work, and I think the common element generally is that alliance between the two, the trust between the two, and the commitment to trying to understand.
If I could work off that, I mean, I see families, and I would see lots of family members who were not identified as having depression, but who did, and who got well as soon as their sibling or their parent or their child got well, okay? So, and by the way, that's the thing now that we're doing these brain imaging studies. We see that psychological things, just as well as pharmacological things, change the brain, okay? So that this issue of psychology or even belief, and I think that psychiatry was inappropriately unfriendly to religion, on the one hand. On the other hand, I think eventually I'm going to want to see some data to tell me that this is a good thing to do for people.
Yeah,
okay?
and in even Dr. Gold presented slides where you had, for example, altruism. There could be issues of social good, faith-based treatments, or at least aspects, self-rewarding, being part of a group, a network, a family that does go that is actually affected with depression, and those things altogether might help depression. So we don't think it's a magic drug, a magic therapy, but it's really the totality of the individual and the family and the community that's going to be important in the heal.
This is a strange disease. We're using the model, but it's a strange one because it comes and goes even without us doing anything on the one hand. So, but the thing I would tell you is when people, we can tell when there's somebody in one that just isn't going away. And on the one hand, the kind of things you're talking about in some ways you'd like to say are even better than simply being treated for your symptoms, right? It's about, real purpose and that sort of thing, and altruism and that sort of thing. So, but it's very hard to access that if you're terribly depressed. So I just don't want to deprive somebody of something that I can demonstrate that it works. There's no stress in my language. That's right, your language, that's right. That's right. No, it's very interesting. That's right.
So I could know, what is your language, so I can know the example?
In your language. What's
your language?
What's your...
Okay.
Actually, it was interesting because there was an interesting study done from the Department of Mental Health at Hopkins on psychotherapy and interpersonal psychotherapy in Uganda in women with milder depressions, okay? And Myrna Weissman, they called Myrna, who's at Columbia, a wonderful woman, who developed this interpersonal therapy, and she's very rigorous. They asked her if she wanted to be involved, and she said, yeah, that sounds really interesting, but we've got to show that our 9 basic constructs of interpersonal therapy can translate into that culture. And 8 of them translated fine. The one that didn't translate at all, loneliness. Because they're never alone. Right, exactly. So it's very interesting. Yeah, those things are all relevant. Yes, sir. Yes, ma'am.
Hi, I just wanted to thank you for putting so much of this into layman's language that's understandable to generalists. I was interested when someone mentioned that neuroplasticity increases at the point of depression.
Neuroplasticity increases in the amygdala in depressed patients. That is the component that is responsible for the conscious experience of fear and anxiety. That actually develops neuroplasticity, increases in size, and has a proportionally greater effect on a person's behavior and thinking.
Right. But I think you're also saying in the hippocampus it actually goes down, isn't that right? In the hippocampus, that's where a lot more action is, it seems to go down in depression.
And the prefrontal cortex goes down too.
Okay.
I'd like to ask the last question, and then I'm going to invite everybody to metaphorically attack our speakers at a reception back there. So the last question, which isn't up to being a last question, it was interesting to me that in response to the question about witchcraft, you went to psychotherapy, which is exactly what I was wondering about, and that is the comfort you have that psychotherapy can be part of the treatment, but the metaphor of this being a disease and the way people commonly understand disease or accident or broken leg or something which is heavily biological, one would not think that let's get a psychotherapist in here to help them maybe deal with the symptoms, but not as part of the cure or the remission. And I'm still struggling to understand something, and that is the extent to which this depression of various kinds that you all have described can be considered or ought to be considered physical if you still want to include psychotherapy in not the cure but the remission.
Yeah. I think we don't know really what systems entirely transduce the depressive syndrome, but if the stress system is importantly involved, then psychological stress and experience play a great role in how the brain is going to be wired and the extent to which a depression can develop. And so I think it's understandable that a biological disorder that is responsive to stress is responsive both to medication and to psychotherapy.
But Well, let me add, and Phil started off this way in his talk about psychotherapy, and appreciate his reminding me of my teacher, Jerome Frank, who when he studied psychotherapy, he was the first great researcher of psychotherapy. He studied the things that were different between psychotherapies, or the things that were common between different psychotherapies. And the alliance with the patient seemed to be the most important thing. Now today, the trend is to teach what you do in the room. Is this method, IPT, better than CBT, better than DBT? And I think those things do matter. You can show they do have some difference. But I think the alliance probably still carries a lot more, number one. And I always say that, you know, first off, that the psychotherapy is for the person. It's not, if you could show me that psychotherapy never cured anyone, would I stop doing it? Not me. If I don't address the suffering of my patient, I have no right to be their doctor, okay? So how you do it is one thing. But if we don't listen and talk to our patients, get to know them, let them get to know us enough, I don't think we're doing our job. And that's one of my problems with taking the disease model as if and reifying it, okay? All models are wrong, okay? Yeah, thank you.
Ladies and gentlemen, please.
This has been a presentation of the Library of Congress. Visit us at loc.gov.